thank you everybody for coming. I think we've got a really good set of presentations today. If you could just type in chat sort of who you are and what organization you're with, that would be great, since there's enough people that we're not going to have time to do like round robin introductions. The agenda for today is pretty straightforward. We have four speakers, or four groups of speakers. Kim Radford and Holly Wilson, who I've had the pleasure of working with on the equity action team with Department of Health and Human Services, are going to be talking about the work that they're doing. And then we will have Ann Meringer coming on from the U of M Healthy Behaviors Optimization Program, talking about the quit line and cessation. We will have a lunch. It will be on your own. We don't have anything served virtually. Unfortunately, we haven't gotten that far yet. But then everybody's going to want to return at 1 when Minu Jones from Making It Count talks about the local efforts that are really making huge progress to ban the sale of menthol and flavored tobacco products in local areas, primarily Detroit, Grand Rapids, and Washtenaw County has an effort as well. Minu is going to be talking mostly about the Detroit efforts. And then finally, Amanda Gallagher from the Department of Health and Human Services again will be talking about sort of the next steps in what tobacco is policy is going to be looking like. And then finally, you'll have to deal with me again. And before we get into all of that, I just want to give everybody a real quick update on what's been happening at TFM, because this last year has really seen a ton of movement. So why can't I advance my slide? Okay, there we go. Sorry about that. So as of right now, there is a bill package that's waiting for the governor's signature. It is a package of 6 bills. Many of them are linked together, though, and almost all, and they all have to do with raising the age of sale for tobacco products to 21. This may be confusing because the federal age of sale for tobacco is already 21 and has been for a couple years, but Michigan's age was still 18. This meant that local law enforcement and health departments weren't able to enforce it at 21. These bills will bring that in line with the federal standards and hopefully allow for better enforcement and a reduction in violations. Michigan's one of the worst states in the country in terms of selling to underage purchasers. So even though it takes 6 bills, the primary thing that it does is raises the age. There is one arguably negative thing, and that is one of the bills lowers the taxes on FDA modified risk products. These are tobacco products that are meant to allow people to continue smoking, but hopefully in a more healthy fashion. They have fewer, they have a lower percentage of tobacco and of nicotine in them. They are not cessation products, so they do definitely still have risks. They are meant to help continue, and there is concern that lowering the tax on those products will make them more appealing to youth and people that aren't smoking, because we know that price sensitivity is one of the big things that people stop. The governor is expected to sign this bill package probably today or tomorrow, and in the real near future. And Tobacco Free Michigan, along with the Keeping My Kids Tobacco Free Alliance, we've been trying to strengthen these as much as possible. The second main area that we've been working on is trying to increase the state budget. Many of you, for the tobacco control program, this was probably one of our most successful grassroots efforts. I put out a call to ask people to contact the governor or legislators to try to raise the tobacco control program budget up to $5 million. That was a target set by the American Cancer Action Network Society, and many of you responded, and just thank you everybody for doing that. We didn't quite make it to the $5 million mark, but we did still get a $500,000. We got halfway there, to just under 4.4 million, roughly a $500,000 increase for the department. Michigan cessation and prevention funding is horribly underfunded. Many of you have heard me say that the CDC recommends that we spend about $110 million in cessation, and currently we spend under $2. This will go a little ways to addressing that, hopefully, but obviously there's still a long ways to go. TFM has also been working with the local menthol bans, and I know many of you have as well. I recognize a lot of the names. Minu's going to talk more about these later, so I'm not going to go too far in, but we have coalitions that are forming in, or have formed, in Wayne County and around Grand Rapids, looking to stop the sale of menthol and flavored products in those jurisdictions. We are constantly looking for more people to join in, more organizations. If you are in Wayne County or Grand Rapids and you have not heard of these coalitions yet, please contact me so we can get you involved. If you haven't, or aren't, please do consider signing a pair of resolutions of support. One is for organizations and one is for individuals. These will focus on, they showed support for banning menthol and flavored tobacco products anywhere in the state of Michigan. And they'll be used to present to the city councils, county commissions, to show that these aren't just local efforts, but something that people from across the state and across the country care about. Those resolutions are at tobaccofreemichigan.org. I will throw a link in the chat right now. And you can find them. They just take a minute to sign. Please consider going there right now. Finally, an update from last year. Right before the conference, there was a bill introduced in the Michigan House that would make underage possession of tobacco into potentially a jailable crime. That wasn't necessarily the intent of the sponsor, but that's what it did. And we had a number of you guys jump on and testify in front of the committee that purchase, use, and possession laws like that are not effective at preventing underage use and are bad practice. The sponsor listened to that and they have been fixed. And that had actually happened as of the last conference. The bills have not moved since then, but a copy of the fixed version was included in the tobacco retail license package that is in front of the Michigan Senate, and is my final point here. A couple of, oh, that's a bad typo. You never see typos until it's too late. Sorry about that. The bill package was originally 6 bills and included some of the age of sale restrictions, or raising the age of sale. The age of sale parts have been raised. The rest of the tobacco retail license package is on hold. TFM, and again, with the Keeping My Kids Tobacco Free Alliance, we put a lot of work into that last year, trying to get those into a state where they would include meaningful enforcement and be a real positive, as opposed to sort of the sham bills that they are right now with little to no enforcement, no penalties. So that those negotiations sort of are on hold. I think as the election season happens, I don't expect much to happen until potentially after the lame duck. But it is something that we are continuing to monitor, and for everybody that has been talking to your legislators, thank you for that. It really has made an effort. And as we are going into campaign season, I urge you to, anytime you're out and you see one of your candidates at one of the coffee hours, or they come to speak to a community group, ask them about talk to them about the importance of having strong retail licensing. Michigan's one of only a handful of states across the country that doesn't, and is part of, I believe, is part of a big part of the reason why our compliance rates for sales to underage youth are so bad, is because we don't have real meaningful ways of penalizing those actions, such as removal of the license. Oh, I lied. One final thing is just a reminder that the FDA's menthol ban is accepting comments. This is a rules proposal to ban the use of menthol in cigarette, 2 proposals, as a characterizing flavor for cigars and cigarettes. They are accepting public comments. At last check, they had over 150,000 public comments. The industry has been really pushing people to go in and oppose these rules. Again, if you go to Tobacco Free Michigan's webpage, there's a link to the comments, along with some sample comments and a webinar that I hosted with Amanda at the beginning of June, sort of talking about the process. So I really would urge people to do that. finally, if you go to TFM's webpage, our mini grant applications are open. They were in the last newsletter. They will be in the August newsletter as well. These are small grants for pilot projects and really looking to focus on heavily impacted groups. Paperwork is super light because we understand these are small grants. But the deadline for that is August 15th. I strongly encourage anybody to apply. If you have any questions, please contact me. And finally, we are always looking for more members to join our board of directors. I think we're going to be adding a couple new ones today, but we still have a handful of open slots. So if you have any interest in joining, please do. We are always looking for more. And that is everything I have. I don't want to take up too much more time for away from Kim and Holly, but if anybody has any questions about any of that, I am happy to answer that. Yes, CEUs are available for this. Lou, you can get it's worth 4 credits for social worker and I missed the other. Yes.
Big BAP.
Yes, thank you. I was completely blanking on it for just a moment. Any other questions for me? Okay. Oh, and on the topic of CEUs, there will be a questionnaire at both at lunch and at the end where I'll collect your information.
Well, I'm not as aware of the thought behind the menthol. Will that be addressed today? Because menthol's been around forever, so I'm not really familiar with the background on why restriction of that. So I just wanted, I don't need you to explain it if it was somebody else's topic, but it was a question I had today.
Yeah, absolutely. So Minu will be talking about that more, but basically menthol and flavors in general are, they make it harder for people to quit in the first place. And menthol in particular has been targeted at demographic groups over time where, so it has a very disparate impact across communities. And it was excluded from the flavor bans in 2009, I believe. But yeah, it makes it harder makes it easier for people to start by presenting a cooling flavor in your throat. That also makes it harder to quit. And I apologize for the garbage truck right outside my window if you can hear that. Okay, so with that, I'm going to throw it over to Kim and Holly. Kim is the executive assistant to Michigan's chronic disease director, and she's the lead of the Michigan Equity Action Team. And that is another typo. Excellent. I'm doing great today. The Equity Action Team, I'll let them, they'll talk about it, but I've had the pleasure of working with them for the last few months now, and it's really going to be it's a really great program that they're doing. And Kim's been a state government worker for 23 years, supporting the work of consultants, managers that work to impact the health of our residents. Holly is the program coordinator for Moving Forward Together, which includes facilitation of the My Race team. Holly got her bachelor's and master's from Central Michigan. and also has 24 years of experience working in public health, nonprofit health insurance, and substance abuse, including program management, operations, and quality improvement. Yeah, with Kim and Holly, I will stop sharing my screen and start letting you guys share yours.
Thanks, Carl, and thanks for having us today. Yes, Kim and I are here to talk about some of the equity work that is happening within our division at MDHHS. In the chat, while I get situated here, I included a link to our presentation. We're actually hoping this becomes conversational at different points throughout. So we are going to have you interact with us through clicking on that link. It will send you directly to our presentation where you can input some information as we come to particular slides. So let me get my slide presentation going here. And I apologize, I'm working with one screen today, so I'm toggling back and forth here. Share. Let me put this into full view for you. There, does that work? Can everybody see that all right?
Looks good.
Okay, great, thank you. So yes, Kim and I are here to talk with you today. This is our contact information. We'll repeat it at the end so that if you have any questions following our conversation today, feel free to reach out to either one of us. Oh, somebody's already started. So we're going to practice getting used to kind of this interactive slide. So if you can click on the link that I included in the chat, that will take you to the slide presentation. If you go to slide 3, we'll practice using it, and it's just a question of share what you love most about Michigan. And these are basically sticky notes, so you can click onto any sticky note that someone else is not in and start typing away. I'll just give you a couple minutes to kind of get used to this interactive nature, but we're hoping that this helps us share different ideas throughout our discussion today. So somebody has shared trees, and I'm going to escape out so that I can see what's happening here. There's also slide 4, 5, and 6 as extra space for y'all to share. Issues here. Okay, so then I can share with you and show you what people are inputting here. The water, the seasons, the lakes, nature, seasons, hidden gems in our state, friendly people, freshwater beaches, beautiful lakes. Let's go to the next one. Great. Okay, so I think you guys got the hang of it. So I'll have a couple more of those as we go through the presentation today. Like I said, we want this to be very interactive, so feel free to raise your hand. I'll do my best, and Kim will help me kind of monitor the chat to answer questions. And if we miss anything or you think of something afterwards, like I said, feel free to reach out to either one of us. I wanted to start with kind of a high-level look at some of the efforts going on at MDHHS around equity. Our department as a whole has a diversity, equity, and inclusion plan. The Office of Equity and Minority Health within MDHHS put out a report after COVID hit us. It was a very rich and robust report that we've used in our work as we've worked through the My Race team, which I'll talk a little bit more about. The Office of Policy and Planning, it has put together a social determinants of health strategy, which also supports the work we're doing. We have the Bureau of Health and Wellness, which has a Health Equity Council. We utilize them very often to help us craft language, make sure that we're representing the Bureau correctly, that we're hitting kind of the markers that are on their priority list as well. And then, as Paul introduced us, Kim and I both work in the Division of Chronic Disease and Injury Control. And 2 years ago, we launched the MyRACE team, which is the Michigan's Real Adaptive Changes to Equity team. And that's primarily what we'll talk about today, since that is our sphere of influence. All of those bits that I just shared, I picked those out because they all support the work that we're doing. The Diversity, Equity, Inclusion Plan is kind of where we started with, oops, sorry about that, is where we started. And this really gives us the base from where we're working from. It is lengthy, but it's incredibly rich, and it hits on why we're doing the work that we do. And normally I wouldn't read a slide, but I feel like reading this and hearing it helps reinforce the message that it creates for us. And so it says, our approach to achieving diversity, equity, inclusion is rooted in principles of racial equity. We have chosen to have an intentional but not exclusive focus on race as a way to address systemic racism and other forms of oppression and exclusion. Our racial equity approach allows us to design policies, practices, and strategies that result in fair and equitable opportunities for everyone. Using this approach compels us to understand the historic and current drivers of health and social inequities, to identify how MDHHS contributes to and can deconstruct these inequalities, to work in partnership with communities we serve to achieve equity, to use statistical data to assess and monitor the impact of diversity, equity, and inclusion initiatives on the workforce, to monitor the effectiveness of our efforts, and to ensure sustainability. So again, that creates the base from all the work that we're doing right now in the equity area. Like I said, it's very robust, and we're doing our best to work towards this plan and this goal. Our division created a strategic plan that was to cover the years 2019 through 2024. And as you're all we're well aware of, COVID hit in 2020. And so the timeline of this strategic plan has become a little bit more flexible. But wanted you to see what the division is aiming for within their strategy, which is a commitment to culture change, working with our partners, data-driven decision-making, maintaining processes for accountability. The one centering community voices I wanted to highlight because that's what you'll hear Kim and I talk a lot about today. So we're back to our interactive strategies. So again, going back to the Google Slides, and I apologize, I'm not sure what slide number we're on, but it's probably about 8 or 9. What does equity mean to you? And it can be, a very detailed description. It can be a broad description, but if you'd like to share what equity means to you, I think that would help us move into the next stage of the presentation. So again, go back to your slides and go ahead, and there's a couple different slides with sticky notes that you can share.
It's slide 11.
Slide 11. Thank you, Kim. And I'm going to keep it in this view if that's all right, because it's a little bit easier for me to maneuver through. So we have having what you need to succeed. So what does equity mean to you? Having what you need to succeed. Equality of opportunity and access, everyone having same access to same resources, working to improve outcomes, justice, deconstructing, everyone having a fair chance at health and well-being, removing systemic barriers. These are great. Unique tools that fit the situation. Great. And these are all right. There's no wrong answer to what equity means to you and the work you're doing and how you can impact it. So feel free to continue sharing because obviously you'll have access to this as we move through today and afterwards. So now that we kind of talked about what equity means to us, are there ways that your organization is addressing equity, working to advance equity? Are there certain things that you're initiating? I would love for you guys to share this. This is a space for us to share the good work we're doing. We're all at different points in this work. So on slides 13 and 14, if you want to share how you are advancing equity, the things that you have highlighted or prioritized within your organization. Great. So we have collaborating with local tribal partners, focus groups for vulnerable populations, letting them tell us what they need, education for clients, outreach events, commitment to diversity, equity, inclusion, and social justice. All of our activities through the equity lens. Great. Awesome. And then lastly, what barriers or challenges are you encountering as you do this work, as you, prioritize equity and try to advance equity in your organizations? What are the barriers or challenges that you're facing? So we have implicit bias, social determinants of health. I know for us, and you'll hear this through the presentation, institutional policies and processes that are based in racism that have existed forever and overcoming those. We are just a small division, and so impacting those at our level and then higher is going to be a journey for us.
Ollie?
Yes.
I don't know if you can hear me. A lot of us, it says that it's read only because of due to high traffic trying to reconnect. So I just want you to know that some of us aren't able to comment. And so no need to think that maybe half of us don't even care or aren't there.
I appreciate you saying that. And I wondered because it did kind of glitch for a second and then I wondered what was happening. So thank you. I appreciate you sharing that. I will continue on this network, but if we continue to have trouble, I will try to switch to a different network. I'm not sure if it's my end of things or what. Okay, so they're all coming in now. So access issues.
Might it be a good idea for people to put maybe their comments related to barriers or whatever we're discussing in the chat?
We can share them here. People can come back to this. They're flying in now. So you can share in the chat if you'd like to. You can also unmute. They're coming in really quickly now. Historical marginalization and oppression of various groups, understandable lack of trust in the healthcare system. Exactly. And just to save time, we're going to skip through how have you addressed the barriers or challenges in your equity work. But as we're going through the presentation, please feel free to come back to slides 17 and 18 and fill that in. I want this to be a document that you can refer back to, and it obviously helps us kind of understand what's going on for others as well. So 17 and 18, how have you addressed the barriers or challenges in your equity work? All right. So I am going to switch to more of my full screen so you can hopefully see this better. Not sure why, but it requires me to stop sharing and go back to it. All right, here we go. So Michigan's Real Adaptive Changes to Equity, the MyRace is the initiative that Kim and I both work on. I am the coordinator of that, and we would like to share kind of some of the work that we've accomplished throughout the last couple of years. We started in the summer of 2020. It was an opportunity through the National Association of Chronic Disease Directors. And this was an 8-week training program that they offered on the psychology of change. And we got a small group from our division together who participated in the 8-week training session. At the completion of that, we added staff to our team so that we had representation from every section of our division, and we named it the MyRace team. And like I shared with you earlier, we're committed to the racial equity work, and the resources I shared on one of the first slides are references and the base for our work. We started a lot of our work working with the Southeast Michigan communities. It's a very obviously dense and diverse population. And so as we work through this, know that the stakeholders that we were working with external to MDHHS were primarily in that region of the state. So where we've been with this initiative, we came out of the training with in 2020 wanting to do a health equity lab. That was kind of the primary goal of that training. Was at the conclusion they wanted us to facilitate, coordinate a health equity lab. And so our team was really excited and gung-ho, and we knew this work was important. And so we immediately started talking about what this equity lab was going to look like. And as we started planning it, we realized we are like probably 10 steps ahead of where we need to be in this process. We found that in talking about what we wanted to do in the health equity lab, we were making a lot of assumptions based on our role within the state. And what we decided was we need to take some steps back, and we really need to talk to our stakeholders and understand from their perspective what some priorities were, what the barriers were in working with us, and we really wanted to connect with our communities. So what we did is we held some stakeholder workshops, is what we called them. We had 4 separate sessions of these workshops, and they were all facilitated by an external facilitator. Nobody from the state was present during these, from our team was present during these workshops. Our facilitator was, again, from the outside, and she really was able to create a safe, kind of open atmosphere for everybody to share what their interactions with MDHHS had been, what some of the barriers or frustrations were, going through the funding opportunities and the barriers there. And the 4 separate sessions were, again, to create a safe space. We had one session was for our external community members. One was for our external community organizations. So those groups that are deeply rooted in their communities, understand their communities, represent their communities well. We had a 3rd session for more of like the corporate organizations who might be providing services in the Southeast Michigan region, but aren't as deeply rooted, might not have kind of their finger on the pulse of what's happening in the communities quite as well as some of the community-based organizations. And then we had a session for our internal stakeholders wanting to know our internal staff, what is preventing you from working more closely with communities? What are the barriers? What are you hearing from your partners? How are you selecting your partners? And so we took that information, we gathered all of that data. Our facilitator shared a wonderful report, and we then went to the next step of having some community conversations. So we gathered those same groups. Initially, we gathered them separately so that we could dig deeper into some of what they had shared in the workshops, allow them to express any additional thoughts they had. And then we had one that was a joint conversation with our internal and external stakeholders. That was to get them comfortable working with each other with the goal of moving towards this equity action lab. We wanted volunteers from these stakeholder groups to raise their hands and say, yes, we are super excited about this effort that you're putting forth. We want to participate in this equity action lab with you. Sign us up. And so that was our 3rd phase of where we've been. In the fall of 2021, we initiated an equity action lab, which I'll go through some of the details of in just a second. But this consisted of stakeholders from internal to our division and to MDHHS, as well as our external stakeholders. And then finally, that created an equity action team, which Kim's going to talk to you about in a bit. I just wanted to share some of there were 4 common themes that came out of the stakeholder workshops. One of those being community engagement, and I'm not going to read through this slide, but this was not a surprise to us. We knew that our relationships needed to be better. There were frustrations both externally and internally to having time and resources to really dig deep with our community partners and our community members. Another theme was data transparency. So sharing, what we're gathering from everybody in our, multitude of surveys and our multitude of questions and reports. So data transparency came up as a common theme that was heard throughout these workshops. The bureaucracy. So some of our systems, our policies, our processes were just really frustrating and difficult to work within. And then a disconnect with our division specifically. People didn't understand who our division even was, how we were connected to other, offices and divisions and the work that we were doing. So those were the 4 common themes. And we really grabbed on to the community engagement. We felt as a team that was a really core theme that needed to be addressed before we could potentially impact any of those other themes. Within the community conversations, again, we relayed that data and the feedback that we had heard in the workshops. Our aim was to bridge these groups together and build relationships across all of these groups so that moving forward, we would have a really cohesive group moving into a health equity action lab. So what is an equity action lab? This is what we shared during the community conversations. We wanted to educate them about what our ask of them was, what our plan was, but I thought this would be helpful for all of you to understand as well. But an equity action lab is a really intentional, focused group of people working towards the goal of fixing an isolated situation that they decide is an isolated situation, that they decide is something that they want to work on. It sets really ambitious goals and aims to work towards, and the actual work on the change item occurs in this sprint phase or this 100-day action phase, and we'll talk a little more about that in a bit. And after that action phase, you come back together and you say, okay, what worked, what didn't work, what do we need to change? How do we want to move forward? This Equity Action Lab in the past has typically been a 2-day, really committed 48 hours of people working together. We obviously had to adjust that, and we did 4 different sessions in a virtual setting. So 4 hours in 4 different sessions. So it was a big commitment we were asking of people. And we understood that. But the goal was obviously to have them be able to share their voice in the process, to be part of the process, to be part of the change. It really is an all-in effort, and we explained that, they were going to impact the changes that we were looking to implement across our division. The biggest thing, that we wanted them to understand is that we did respect and value their time. We paid them for their time throughout these processes at $50 an hour. So they were compensated. We wanted them to understand we respected and valued their input, their time, and we understood this was a big commitment. So we got a great group of people from our internal staff and our external stakeholders to raise their hands and say, yes, we'd love to be part of this process. Sign us up for this action lab. And so this just kind of gives you an idea of how the labs were structured. And so we did sessions 1 and 2 in 1 week. And we just kind of reviewed the model. We went through a lot of different exercises just to get them in the mindset of, making these changes, mapping out what the change idea was going to be. We came back, I think it was a couple weeks later, and did sessions 3 and 4 to brainstorm, these change ideas, talk about how that would happen, what that would look like. And again, generate some interest and excitement about moving that forward in the action team. This is just a nice chart of the Equity Action Lab structure. So you can see the prep phase is a lot of what the MyRace team did before the Equity Action Lab happened. So we did the stakeholder workshops, we did the community conversations, we really gathered some of the input and feedback from our stakeholders. The Action Lab phase is obviously the Equity Action Lab phase. The sprint phase is the action phase, that 100 days of really intense work on this very isolated, specific change idea, and then a sustain phase. Just some important things, I think, if you ever kind of decide to journey down this path and pull teams together. I just wanted to highlight some of the things we found really important. One was to create some shared guidelines and norms, and we did this similar to the sticky notes thing that you guys just did. We put it out to the entire team. What do our shared guidelines need to be? What are our norms? And you can see some examples of what came out of that process. It was very intentional. We wanted it, again, to feel like a comfortable place where everybody was included and felt like their voice was represented. We made sure to highlight the principles for improvement. There are 5 of those, obviously knowing why you need to improve, having a way to have constant feedback through the improvement process, developing an effective change that will result in improvement, testing that change, and knowing when and how to make that change permanent. I liked these like graphics. I thought it made a lot of sense to me. It resonated with me. Sometimes you hear the words, but seeing it made a lot of sense. So, you know, our usual approach to change is really just to plan, implement, or design, you know, get this all worked out, and you have this lovely wireframe or this workflow that you're like, yes, this makes total sense. You get it approved by your director and you implement it and life's good, right? Not always. Often after implementation, you're like, oh, we didn't think about that. Oh, we forgot to ask this person about how that would impact their work. Oh, we forgot this. So what we tried to present in this Equity Action Lab was more of a quality improvement type of approach to this change idea. We wanted to design it as a group, but then we need to put it through a test process. Does this work? We need to gather feedback during that test process. We take that back and we make modifications to our original design. We test it again with maybe a new group of people, maybe the same group of people, and see again until we get to a really solid product, a really solid change idea, a really solid example of what you're going to implement. And the way you can get to that, I know many of you are familiar with the PDSA cycle, but that is definitely the core of a lot of the work that we did within the Equity Action Lab and the action team, which Kim will hit on. But we did a lot of planning and, you know, worked through some questions and what we thought and some assumptions, planning out all the logistics. We were kind of in the do process through the action team, which Kim will talk about, carrying out this plan, creating whatever that change idea product is going to be. We're studying, you know, eventually Kim will get to that too, but we're going to be in the studying process of like, okay, analyzing how this is working, getting feedback from people who are implementing this in like a test phase or a pilot phase. And then you either go back to the drawing board in the act phase, you try something different, you make some tweaks, maybe you scrap the whole thing, or maybe you decide, nope, it's perfect. Let's put this into implementation and see how this goes. So out of our own Equity Action Lab, I'll try not to read this, but the change idea was very specific. There was a lot of conversation about community engagement was obviously the broad stroke theme that came out of all of this. People were really concerned about MDHHS staff being accountable and understanding the expectations of community engagement. They wanted to work it into like a performance evaluation so that it could be a goal of all staff. And so that's kind of where the change idea started to go. But when we came down to the aim statement, like what is our ultimate goal here? You'll see that it really hits on community engagement, having the resources to do that properly, having staff feel that they're equipped to do really good community engagement, and having our external people feel like their voices are being included in planning, decision making, and things of that sort. So these are all of the items that came out of the Equity Action Lab with a real focus on community engagement. And so what happened was then actually, let me let me pause that thought for a moment. What we did, again, for community engagement, we said, hey, let's take a look at this continuum then. Community engagement is obviously a priority. This continuum really lays out, how you kind of move along the spectrum here to get to some really great community engagement. We asked in the Equity Action Lab, where do you think MDHHS is at this point in time with their community engagement? And what we heard was that you're kind of in the outreach place. You're kind of way down here in this spectrum. There's some community involvement. It's pretty high level. It might be, surveying, but we aren't feeling super engaged or involved in decision making. And so we asked the group, okay, realistically, what's our goal? As we're looking through this aim statement, as we're working through this change idea, what is our goal on this spectrum of community engagement? Where do we want to be? And they identified that really collaborate was the first goal that they wanted to set forth, that building trusting relationships with our partners, with our communities, having them be involved in, a real two-way communication that keeps them engaged in our strategic planning, that keeps them engaged in our decision-making. That was the goal. And so at the end of the Equity Action Lab, we had, we asked, hey, okay, everybody's really passionate about this. You've committed so much of your time and your effort into creating this change idea, creating this aim statement. Who wants to participate in this 100-day sprint and take forth those change ideas and really make an impact and isolate something we're going to implement within the division, and we're going to make a change here. And so fortunately, we were able to get some volunteers out of the Equity Action Lab who said, yeah, sign me up. I'm ready to do this work with you. And Kim was one of those. She is obviously an internal stakeholder. And Kim was kind enough to say, you know what, I can take the lead on this. And so I'm going to turn it over to Kim so that she can share with you how she approached the Equity Action Team responsibilities. So Kim.
Hello, everybody. I'm so happy to be here, and I am just thrilled to have led and worked with a great group of people who are passionate about advancing health equity and racial equity. It just was a real pleasure to work with the folks that are on our team. So what we developed was a team called Michigan Equity Action Team. For short, we call it MEET. And again, we just worked on developing what community engagement is, how we can improve in it, and therefore also improve bi-directional communication. So on your screen is a team charter that we developed. Now, so we moved in from discussion about what was needed to action, and therefore the action team. Our South Michigan partners that were on the Michigan Action Team were Detroit Food Policy Council, Beaumont, and Tobacco Free Michigan. So you all know Paul, and Winona Bynum was from Detroit Food Policy Council, and Alicia Jackson from Beaumont, with two additional internal, well, three including me, internal stakeholders made up the team called MEET. And so when we moved from the discussion that came out of the lab sessions to this MEET team, we developed a team charter, a quality improvement team charter, where we focused on the things you see on the screen. We wanted to name our team. We wanted to define the problem or the opportunities, just highlights of it. We spent a considerable amount of time developing, the change idea, the aim statement, and success measures following the PDSA cycle. We also, we really focused, as Holly said, on making sure we engaged our external partners and always prioritized their input and their engagement along the way. We scheduled meetings, so that it could be on everybody's calendar for the process during the 100-day sprint that we decided to take on. And we one of our main goals was to always prioritize the time and the schedules of our external partners, because we want to value their input, their time. You know, we just felt like it was really extremely important that we always prioritize them. So again, with the 100-day sprint, we decided to develop a timeline of events, tasks that you can advance, I think, to the action planning. The action planning grid here is where we identified specific tasks and put it on a timeline and assign people that were responsible for doing that during the 100-day sprint. Out of that, we decided to develop a toolkit called community engagement. And the community engagement toolkit was where our staff, you know, it's a resource where our staff within the division of MDHHS, chronic disease and injury control, could access to learn about this goal of engaging in community service, not community service, but community engagement at a higher level with our external partners. And so in this toolkit is all kinds of information relative to that process and how to get better at it as an employee in every role. So I'm going to give just a few highlights of the toolkit. We used the format of OneNote, and I don't know if you all are familiar with that, but it's a notebook type format online, and it's really a beautiful format. And so we've got several categories, and within each category is our sub pages that elaborate on the various things. So obviously we have a definition of community engagement in there. We developed an introduction. We talked about principles and strategies of community engagement. We also highlight and talk about strategies per role where our staff can understand how their roles play into community engagement, whether you're administrative assistant, consultant, finance team person, a manager. We wanted to make sure that everyone in the division felt like they play an important role to upping our game in community engagement. We also talked about in the toolkit how to build and nurture partnerships. We want them also to be aware of some stories, some success stories in our division, so that people in our division can see where we're already functioning well and can see examples of how every section in our division is doing this, but, you know, so they can see how they can also move toward that. We also provided definitions and references, you know, among other things. A whole bunch of stuff is in the toolkit. It's just a beautiful online document that helps our staff understand what community engagement is, where we're going with it, how they can, and provide direction for them in their role about how they can be better at it. So that was what we did during the 100-day sprint. And so after the 100-day sprint, it just wrapped up like July 5th. And after we call this a living document. So after the 100-day sprint was sort of over, we had focus groups. There was 2 focus groups. One was internal and one was external. And what the goal with that and purpose with those groups was to look at the toolkit, evaluate it, and give us some feedback on it. And so we just did that. We are going to incorporate any suggestions and that they have with the purpose of improving it always. Our next plan also is to have a pilot group in our division utilize the toolkit for a period of time. We're estimating 3 months is probably going to be good, so that we can get additional feedback, so that we can be constantly moving toward improvement of the toolkit, so that it's useful and that people feel like there's something that they want to use and that they can use it and there's some ease to it. And again, also part of the next steps are getting management team buy-in. making sure that as we move through the pilot and we get to a point where we're requiring all of our division staff to do this, we got everybody on board understanding what's important, why this is important, and to get everybody's buy-in so that it doesn't feel like just another something to do, or that it's going away. It's not going to go away. It's a priority of our division, and we want all the staff to be engaged in this and be willing to work and operate in it. So we want to have a kickoff for the division staff, to introduce it, to really get buy-in, to really be enthusiastic about it, to do everything we can to make this, just to show how important it is in a very good, positive way, so that everybody will be on board and know their value in it. Again, we're going to require it of all the staff, making it a part of performance evaluation ultimately. So I think it's just been a super opportunity for me. And I'm just happy again to have worked with a great staff. And if you have any questions, you can certainly pose them. I think that wraps up my portion of it. I hope that was good.
Yes, thank you, Kim, so much.
Yeah, thank you, Kim and Holly. And thank you for getting us sort of back on track after I rambled on for so long. Does anybody have any questions for Kim or Holly? Lou is asking, how can an organization volunteer to be a participant?
So Lou, we are now in the pilot phase. So we've constructed the toolkit. We're going to pilot it internally. But, we're constantly planning kind of the next iteration of what's our next steps now. So if you want to reach out to me directly and let me know that you're interested in future, in future initiatives where we're looking for some external volunteers, that would be great. I'm just writing you down right now. And so I'm going to, Paul has the slides shared. There's some additional information on there and ways that we can share back and forth. So hopefully we can share this. And so after the conference, if you want to go back to it or refer back to it, then feel free to share. And yeah, thank you for joining us today. We appreciate it.
Thank you so much. So our next speaker is going to be Ann Maringer from Healthy Behavior Optimization from Michigan. While we get her set up, we'll take like a 2-minute break so everybody can go grab a cup of coffee or go to the bathroom or whatever. And it really will be like 2 to 3 minutes. So go ahead and take a short little break, and then we will get Ann going. Okay, I'm not sure if it's actually been 2 or 3 minutes yet, but my clock says it's 11:07. I was talking at 11:05, so we will get started. So our next speaker is Ann Maringer. Ann joined the Healthy Behavior Optimization for Michigan program back in December of 2001 and serves as their program manager. She has a 30-year history or career with University of Michigan, previously working as a clinical research manager in transplant neurology, pediatric surgery, and behavioral medicine nicotine research lab. Ann holds a Bachelor of Arts in Psychology and Studio Art from Kalamazoo and a Master of Science in Clinical Trial Design and Statistical Analysis from University of Michigan School of Public Health. She is also a board certified national and health wellness coach. And with that very impressive introduction, I will turn it over to you, Ann.
Thank you, Paul, for inviting me here today. Can you see my slides and hear me okay?
I can see your slides and hear you okay. I was also supposed to give co-host permission to somebody, but I forget what their name was.
Aria Young is joining me today. She's part of our design team, so we have her to thank for the beautiful slides today. And she's also going to help by posting links in the chat for me and answering any questions again. I do also want to start by letting you know that there may be background noise for me as well. We had a tree fall back in May, just outside of our house, fell into the street, thank goodness, but they've decided that today, as of 10 minutes ago, that would be a great time to replace the sidewalk that buckled as a result of that tree. So here's some thunder in the background. It's just the sidewalk being thrown into the back of the trailer.
Don't hear anything.
And my dog protecting me.
Well, we do hear the dog.
Yes, he does a good job of protecting. So falling sidewalk forward. So again, thank you for letting me present today. I really appreciate it. My name is Ann Maringer. I'm the program manager for the Healthy Behavior Optimization for Michigan, which is a collaborative quality initiative. And I'll tell you more about that in a moment. Dr. Tammy Chang is our program director. She was going to do this presentation, but she's currently on her way to Spain, so she's not able to join us today. So during our time together this morning, I'd like to give you an overview of what Michigan Collaborative Quality Initiatives are, because they're truly unique to Michigan, and we're really doing some great cutting-edge quality improvement work. I'll tell you more about our CQI, the Healthy Behavior Optimization for Michigan CQI, and our mission to make the healthy choice the easy choice. I'll briefly describe the mechanism in place to incentivize providers throughout the state to change their behaviors in order to help their patients make healthier choices through value-based reimbursements, or VBRs. And lastly, I'll review some of the existing resources available for tobacco cessation and how HBOM is working hard to uplift these resources to make them more accessible to providers and patients. And I'll also share with you some of the new resources we've created along the way on our journey so far. So let me start by explaining what the collaborative quality initiatives are and how they are set up. I'll also share a little bit of the great work that's been accomplished so far with the CQIs. So the collaborative quality initiatives, fondly known as CQIs, are Blue Cross sponsored statewide quality improvement initiatives. They're developed and executed by Michigan physicians and are designed to address the most common and the most costly areas of surgical and medical care in Michigan. Blue Cross, Blue Shield of Michigan, and Blue Care Network provide funding for the coordinating centers, provide administrative oversight for each CQI, and they incentivize hospitals and physicians to participate in the quality improvement initiatives by providing reimbursement rewards for participation and performance. Coordinating centers are currently housed within Michigan Medicine and Henry Ford Health. They're led by faculty program directors and administrative program managers, such as myself, as well as other program staff specific to the needs of each CQI. So the coordinating centers provide administrative oversight for each CQI, They serve as data warehouses, they conduct data audits, they do data analyses, they generate reports to share with their participating hospitals and providers, and they conduct collaborative wide meetings. And these meetings are where the physicians, the administrators, and other hospital staff from across the state convene, and they share and discuss this really valuable information. Most of the CQIs work directly with hospitals and physicians throughout the state to collect, analyze, share data on patient risk factors, processes of care, and outcomes. The hospital and physician participants direct and execute the clinical work. So this model allows for participants across the state to work together, regardless of what hospital they're with, regardless of whether they're competitors in the market or not. They work together, they share data, they develop best practices, and they improve care for patients throughout Michigan. The very first CQI was launched in 1997, and since then, over 20 consortiums have been created and sponsored by Blue Cross. Hospitals and physicians who are interested in learning how their organization can participate in some of these CQIs, they can look at this valuepartnership.com website and contact Blue Cross, see how they can participate, or they may already be participating. So how do CQIs function? The coordinating center for each CQI will reach out to hospitals, physician organizations, and providers across the state and invite them to join their CQI as an active participant. The enrolled organizations will then work together to identify the needs specific to that, the goals of that quality initiative, and the potential targets for improvement. The proposed quality initiatives are then shared with Blue Cross to determine mechanisms to reward the hospitals and incentivize providers who participate and meet defined targets.
And can I interrupt you just real quickly? There are a few comments in chat that people are having trouble hearing you. Can you move closer to the microphone or? Possibly?
Yes, I can try to move this up. Is that better? Can you hear me? No. I have a microphone, but I don't have enough ports in my computer to make it work. So is the sound hopefully better now?
Okay, yeah, they're saying it's better. Thank you.
Okay, good. So although the CQIs are sponsored by Blue Cross, data is gathered from all patients and all payers at the participating sites. And the data are unblinded and shared with all participating sites at the collaborative wide meeting. So the meeting attendees actually have to sign a confidentiality agreement before they're allowed into the meeting. And that allows for open and frank discussion on the data that's presented. The sites are able to see how their organization measures up against other organizations in the state. And it's here during these collaborations that problems are surfaced, best practices are shared, and it's here that new ideas are generated for future target initiatives. So Michigan's statewide CQIs include collaboratives that focus in several different areas. Many of them work on surgical improvements, such as MSQC, which is the Michigan Surgical Quality Collaborative, which is dedicated to overall surgical quality improvement to better patient care and lower costs. There's MSTCDS, which is the Michigan Society of Thoracic and Cardiovascular Surgeons Quality Initiative, which aims to reduce the risk of complications and improve treatment for patients undergoing cardiothoracic surgery, general thoracic surgery, and perfusion treatment. Aspire is the anesthesiology performance improvement and reporting exchange. And that is the quality arm of MPOC, the Multi-Center Perioperative Outcomes Group. And they're working to understand variations in care, reduce complications, and improve outcomes. Marquee is the Michigan Arthroplasty Registry Collaborative Quality Initiative, and they work to improve the quality of hip and knee replacement surgery procedures and reduce costs. MBSC is the Michigan Bariatric Surgery Collaborative, and they aim to improve the quality of care for patients undergoing bariatric surgery. There's also a focus on cardiac care with BMC2, which was the first collaborative. And they aim to improve quality of care, reduce complications, increase medication adherence, and reduce adverse outcomes for patients with cardiovascular disease. In oncological care, we have MOXIE, the Michigan Oncology Quality Consortium, which aims to promote high quality, effective, and cost-efficient care for medical and gynecological cancer patients. MROC is the Michigan Radiation Oncology Quality Consortium, and they aim to determine the most appropriate use of intensely modulated radiation therapy for breast and lung cancer patients. For emergency care, there's MEDIC, the Michigan Emergency Department Improvement Collaborative, which uses registry data from child and adult emergency room visits to improve population health and quality of care, as well as MTQIP, the Michigan Trauma Quality Improvement Program, which aims to address variations in outcomes related to trauma-based care, focusing on areas such as blood clot prevention and bleeding control. Other CQIs include MACI, the Michigan Anticoagulation Quality Improvement Initiative, which aims to improve outcomes in patients requiring blood thinners for blood clot treatment and prevention. IMPACT, the Integrated Michigan Patient-Centered Alliance in Care Transitions, and they work to improve patient care transitions from hospitals or skilled nursing facilities to home. MUSIC is the Michigan Urological Society Improvement Collaborative, and they work to improve the quality of urologic care for patients. MVC is the Michigan Value Collaborative, and they use high-quality multi-payer data and customized analytics to help hospitals and physician organizations better understand their performance. OBI, the Obstetrics Initiative, they work to improve maternity care and safely lower the use of cesarean sections among low-risk patients. And HMS, the Michigan Hospital Medicine Safety Consortium, which is focused on evaluating and improving the care of hospitalized medical patients who are at risk for adverse events. So a lot of great work, a lot of outcomes have already been analyzed and published. Just a sampling here of some of the successful work that has been done with these quality initiatives. There's been a 56% reduction in mortality after bariatric surgery. Prevention of 175,000 unnecessary lab tests or blood clot prevention. A 50% reduction in hospitalizations for urological procedures. 51% fewer bleeding complications with cardiovascular care. A 23% reduction in surgical site infections. And this is just a small sampling of all the great work that's been done and is continuing to go on. So these successes got Blue Cross and the CQI's thinking about how to create even more impact on the health of Michiganders. So we've been making excellent strides in clinical care. But if we take a look at why health in Michigan still has so much room for improvement, you can see that a person's social determinants and their economic environment account for 45% of their successful health outcomes. And health behaviors account for 30%. So if you combine those, that's a whopping 70% opportunity to help people improve their health outcomes. So looking at this in another way, let's compare two patients. So the first patient has a lot of comorbidities. They're not very healthy overall. The second patient is very active and healthy. Both of them are scheduled to undergo the same surgical procedure. The unhealthy patient has a top-notch doctor at a high-performing hospital and has a 66.3% risk of complications from that surgical procedure. Alternatively, the patient may end up seeing an underperforming doctor at an underperforming hospital and end up with an 89.4% risk of complications. Obviously, making sure the doctors and the hospitals are trained in best practices and rewarded for performing at highest levels is very important. Now let's look at the healthy patient who has their surgery performed by the expert doctor at a high-performing hospital. Their risk of complication is only 1.5%. This is obviously where we want our patient population to be. What about that same healthy patient if they end up with a low-performing surgery at a low-performing hospital? Their risk of complication is 6.3%. Not as good as 1.5%, obviously, with the higher performing surgeon in the hospital, but still better by far than the outcome risks for the unhealthy patients. So this difference is our opportunity to ramp up the impact of our Michigan CQIs. And thus was born the population health CQIs. So in 2020 and 2021, they began launching things like MCT2D, the Michigan Collaborative for Type 2 Diabetes, which aims to prevent, slow, and reverse the progression of type 2 diabetes, which is so prevalent across the nation and in Michigan. M-Shield, which is very relevant to the talk we just heard earlier, the Michigan Social Health Interventions to eliminate disparities, and they partner with other CQIs to address social health needs in patients and achieve equitable health outcomes. MyBack is the Michigan Back Collaborative, focuses on better care for low back pain. MISIC, the Michigan Spine Surgery Improvement Collaborative, brings orthopedic surgeons and neurosurgeons together to improve spine surgery outcomes. MyMind, the Michigan Mental Health Innovative Network of Clinical Design, works to engage psychiatrists, psychologists, and primary care physicians to improve suicide prevention and care. Inhale, inspiring health advances in lung care, seeks to improve asthma and COPD patient outcomes. And then there's HBOM, Healthy Behavior Optimization for Michigan, and we focus on improving health behaviors. So at HBOM, our mission is to create sustained improvement in health behaviors and health outcomes among patients across the state of Michigan. So unlike the other CQIs that reach out to hospitals and physician organizations and providers and enroll interested sites into their programs, HBOM is a partnering CQI. And that means that we don't work directly with POs and hospitals and providers, but we partner with already established CQIs, that long list of established quality teams. We work with them to improve population health in 3 main areas: tobacco cessation, nutrition, and physical activity. So we really need the help of these already established CQIs because they have the patient's attention during an important moment when the patient is really much more likely to be motivated to make a change in their health behavior. It may be an upcoming surgery, it may be a new diagnosis, it may be a pregnancy. We call this the teachable moment, and that's what we try to leverage to help improve health behaviors. HBOM was launched in 2021, and for our first initiative, we're targeting smoking cessation because, as everyone on this call knows, tobacco is the single most preventable cause of morbidity and mortality in the United States. Some of the CQIs have already been working with their patients on the importance of quitting smoking. Some are brand new to the smoking cessation work. We've found that many physicians who are experts in their specialty are unsure of how to incorporate smoking cessation into their workflow. We also know that every contact counts and every touch point between a patient and a medical care provider is an important opportunity to assist patients with quitting if they're interested in quitting. And national studies show that 70% of smokers want to quit. Unfortunately, our data show that only 15% of smokers in Michigan are actually provided referral or treatment. This is a huge gap, and this is where HBOM and our partners were working to close this gap. These providers that we're partnering with have an amazing opportunity to impact patients' health and patient outcomes. So for this first initiative, our first initiative is tobacco-based. We're partnering with 9 of the CQIs. Each of these 9 partner CQIs work with us, HBOM, to create tobacco cessation measures appropriate for their group because they're each doing different work. And they know what work is being done. It's important for them to be in charge of their tobacco measures. Blue Cross Blue Shield of Michigan approved the measures that were proposed by the partner CQIs, and they have agreed to provide a 2% uplift in the 2023 VBR payments for successful participation. So VBRs are value-based rewards, and these are dollars that are used to incentivize providers to participate in this type of quality improvement initiative. So if the providers meet the tobacco cessation targets that have been defined by their CQI, they receive extra bonus money for their work. And for this first year, many of the CQIs are new to tobacco cessation, and they really are spending this time putting in the effort to improve their documentation or automating their data collection. There are some CQIs that are already doing some work in the space, and their measures are more outcome oriented. we have a pretty good mix of documentation measures across the CQIs and outcome measures. So for example, this CQI, music, the Michigan Urological Surgery Improvement Collaborative, had not previously been collecting data on patients about smoking before this initiative. For them, it's important to start by establishing a baseline. So their first measure, this donut on the left, is the entire population of prostatectomy patients that they see in their practices. And their goal is to document 50% of smoking status for these patients, because they don't even know how many of their patients are smoking. So their first target is to document 50% of their patient population. Their second target is to document whether or not the smoking prostatectomy patients actually get counseling to quit smoking. And so their goal is to document 25% of whether or not those patients got smoking cessation. As another example, one of our other partners, the Institute, they've already been working on smoking cessation and smoking data. So they know how many of their patients have received treatment. And so their target for this year is to increase the proportion of smokers in their patient population, the vascular surgery discharges who are not smokers, to increase that number from 6% to at least 25% of them getting smoking cessation treatment. So for those who are starting out, putting systems in place to begin documentation, they'll be capturing baseline information on where their patient populations currently are in regards to smoking status. Some are also beginning to ask whether or not patients are currently being offered smoking cessation counseling or referral. Although each CQI defines its own target measures for the Tobacco Cessation Initiative, HBOM provides information and guidance on smoking data collection to help them get started. So this chart shows the minimum data recommended and the gold standard for collection of information to be captured. So you'll see in green is baseline measures, the orange are the intervention measures, and the darker orange, I guess that's yellow, orange for outcomes. And then we have what the description of the metric is, what the minimum recommendation for data capture is in each of these areas, an intermediate goal, and the gold standard is to collect all of these measures. So baseline, we want them to at least collect smoking status 30 days prior to the hospitalization of the procedure. And then to do one better, they should also collect the number of cigarettes per day or the years of smoking. The gold standard would be collecting both of those. For intervention, we want them to at least ask, has the patient received any smoking cessation counseling? And for intermediate recommendations, were they offered any services? Yes or no? And then the gold standard is, if so, which services were they offered? So then for outcomes, we want them to at least ask the smoking status 30 days post procedure or surgery. Intermediate, it would be nice if they went out to 90 days, and for gold standard, 1 year post procedure. And then also capturing cigarettes per day and years and what kind of assistance was provided by the healthcare department. The CQIs that are targeting outcome measures are working to increase their rates of smoking cessation counseling and or referral to cessation programs. Next year, all participating CQIs that partner with HBOM for these tobacco cessation VBRs will be required to have at least one outcome measure defined for quality improvement. This first year, we're allowing just some kind of documentation and setup targets, but next year, everybody will be required to try to increase outcomes of smoking cessation and referral. So we also provide guidance on the best practices for adding smoking cessation to the existing workflows. And we share the 5 A's of intervention. Ask about tobacco use. Do you smoke? Advise them to quit. Assess their readiness to make a quit attempt. Assist with the quit attempt if they're ready. And arrange for follow-up so they're not left out there on their own. So this model is provided, this model of the 5 A's is provided as a gold standard by the Agency for Healthcare Research and Quality. And the biggest obstacle to adding tobacco cessation work into the provider's workflow, we hear it a lot. How do I fit this in to my busy workflow? They have limited time with patients and a lot to discuss. And this is just one more piece. So we provide other resources to really help them dive deeper. This is more guidance that we can provide to our partner CQIs to help their sites walk through their current workflow and clearly identify opportunities to improve the smoking cessation work in their areas. So we've taken the gold standard, the 5 A's, and we've kind of broken it down into a workflow. So you'll see that the blue ask corresponds to the blue, what do you ask for this initiative? Do you smoke? And then we break it down into, well, who does this for your organization? How is it done? Is it on paper? Is it somebody interviewing them? When is it done? Where in the process do they get asked? And how is it documented? And who does the documentation? So it really helps them to just walk it through. And if there are holes or variations, they can really kind of hone in on how they want the process to proceed. And here are the 5 A's, just presented another way to help the providers see how the tobacco cessation can fit into their conversations with patients. So every practice has their own workflow, and this slide is a representation of what that might look like. And starting on the left side, the workflow begins with knowing who's a smoker and who's not. So the orange paper icons denote where documentation will be critical to measuring the success of the intervention. The first step of ask and document is an important first target. So for some CQIs, this may be their main goal right now, to make sure the step is happening and being documented. And this step alone often involves a lot of rethinking of processes. Sometimes the sites need to work with their IT groups to modify their organization's electronic medical record data flow or capture. This step can feel daunting for some, but it's really necessary to move the needle forward. It's vital to know if a patient is smoking. If we're going to be asking every provider who comes into contact with that patient to be a part of the cessation process, we need to know who they're having these conversations with. So next comes advise and assess. And we encourage each provider to counsel every patient they see who's an active smoker. So for this initiative, providing counsel requires the provider to counsel the patient with one brief but powerful endorsement, something like, the best thing you can do to improve your outcomes is to quit smoking. And then the next statement from the provider should be the assessment of interest in quitting. If the patient declines, the provider needs to document, or somebody needs to document that the encounter took place in order to get credit for the quality improvement initiative. We don't expect the providers to convince the patients to quit if they don't want to, and we certainly won't be penalizing any providers for that. If, however, the patient is interested, then the provider can follow the process for their clinic to treat, refer, or have another member of the team take over the treatment conversation. Documentation of the assist arrange conversation is an important target also, and it can be options such as offered and declined, treated, or referred. The ask and the documentation of smoking status can happen prior to the encounter between patient and physician. Advise needs to come from the physician. And we hear the challenges. I don't have time. Smoking cessation is an involved process and should be taken care of by the primary care physician. I'm focused on surgery, and that's what I really need to focus on. But we know how quitting smoking can really improve outcomes in a big way. As one of our participating physicians said, I ask because I care. And they tell their patients that very thing. They say, you know, I'm gonna ask every time you come in, and I'm not doing it to annoy you. I'm doing it because I care. And then finally, it's important to assess if the patient is interested. Remember that gap we talked about earlier where 70% of smokers want to quit and only 15% get a referral for smoking cessation? Well, here's how we start to close that gap. Ask the patient if they're interested in quitting. So remember, HVOM is focused on making health the healthy choice, the easy choice. And not just for the patient, but we're working with the CQIs to make the smoking cessation work as easy as possible for the physicians as well. HBOM speaks at many of the partner CQI collaborative-wide meetings, and we emphasize with all of the physician champions who are present at those meetings, the simplicity of ask smoking status, advise, say one simple statement about the importance of quitting, and assess, ask if they're interested in getting some resources to quit. If the smoking patient is interested in quitting, the physician has several options. If they want, they can have a more in-depth conversation with the patient. And HBOM has created some resources to help facilitate these discussions, which I'll be highlighting a little later. If the organization has an in-house smoking cessation program, the doctor can pass the baton to the appropriate person in the work. But what if they don't have an in-house tobacco cessation program and they don't have time to have that discussion themselves? No worries. There are fantastic resources available. Have you ever heard of the Michigan Tobacco Quit Line, for instance? So the National Comprehensive Cancer Network defines the gold standard of tobacco cessation treatment as the combination of pharmacotherapy and behavioral support. Pharmacotherapy includes nicotine replacement therapy like patch, gum, nasal spray, and or medications that have been shown to help with cessation. Behavioral support can include individual or group classes, coaching, or other tailored programs. In order to give patients the best chance of successfully quitting, they should get both pharmacotherapy and behavioral support. This combination has been shown to double the patient's chance of successfully quitting. And HBOM doesn't need to reinvent the wheel. The gold standard for smoking cessation is already available. The Michigan Tobacco Quit Line provides options for comprehensive smoking cessation. They offer counseling in several languages, nicotine replacement therapy, educational materials, and connection to local and specialized groups. We share this information with all of our CQI partners, and we try to make it as easy as possible for the providers to connect their patients to this amazing resource. We work hard on referral materials so the providers don't have to. We provide posters, business cards, and business card holders to the sites if they want them. We have supplies directly from the Michigan Tobacco Quit Line that we can include with our resources, as well as other resources that we've created and curated. As long as they request them from us, we are happy to share free of charge. We've even created some technology using near field communication badges, so NFC badges. So they come with a lanyard so the provider can wear the badge. And if a patient would like to contact information on the Michigan Tobacco Quit Line, they simply tap their phone on this badge and are connected to HBOM's text message. And then we take over, we provide Quit Line contact information, text that to them so they have it in their phone and they can use that to follow up at their convenience. And that's thanks to our design team and all the fun resources they put together for us. So sites enrolled with our partner CQIs can order resources anytime from our website, which is hbomish.org. Providers who are not enrolled in a CQI that partners with us, but still want to use these resources, they're available to download and print for free. Anything that you want from our website is free and available. So I've shown you some of the Quit Line materials we offer, and next I'm going to share some of the other resources we've put together. So here are two of the most popular resources available, which I mentioned earlier. On the top is the medication guide, and this is a laminated card that folds to fit into a lab coat size pocket, and it provides quick reference on medications for cessation and basic dosing information. And on the bottom, you can see the nicotine replacement therapy resource guide. And these have a brief description of the different NRT options on the front. and a brief dosing guide on the back. And these are tear-off sheets that come in a pack of 50 sheets. So both of these resources are available to assist providers who want to have a more in-depth conversation or who want to provide educational materials to their patients. As with all of our resources, providers who are participating with one of our partner CQIs can request to have them sent to them free of charge. But again, they're available to download and print free of charge to anyone who might find them helpful. We've also designed posters that can be requested or downloaded from our website. There are patient-facing posters that can be put in waiting areas or exam rooms, and there are provider-facing posters that help remind physicians about those 5 A's. Make sure that they are asking, advising, and assessing. And we have asked some of the people doing the work at our partner sites to get involved and let us know what they would like to see on poster. This is an example of a suggestion from one of the data abstracts for Sandy and the end product from our HBO design team. So we had a contest at one of the collaborative meetings hosted by one of our partner CQIs, and we asked people to share their vision of what they'd like to see on a poster. So the middle page is the entry that Sandy turned in her idea. And our design team took that and created her vision, which ended up with the poster on the right. In fact, we loved all of the designs that were submitted and ended up creating posters for all of the entries. So you can get all of these on our website, and you can even submit your own ideas if you have some that you would like to see that aren't represented here. In addition to creating beautiful, simple, and usable materials, we strive to uplift the many fantastic resources that are already out there. We're working to become a comprehensive resource library for smoking cessation information for both providers and for patients. So this is a snapshot of our tobacco cessation resource library. We continue to add resources as we find them. If you have resources you would like us to include, please let us know. I believe we're close to the 100 mark with the number of resources that we've gathered so far. And you may notice also that it's searchable. So patients and providers can click on the icons at the top for common search themes like smoking cessation groups and classes. You can use the large icon at the top to find the most common themes. Or perhaps they're looking for an app to help them quit. And you can also look at the little ribbon, these little buttons just below the main ribbon at the top. And these are also common search. So here you can see you can search what's in Michigan, what's at the national level, what has NRT associated with it, what's free, which ones are classes, which ones are in person, which ones are virtual, counseling options. So those are the quick categories we've established so far. There's also a specific, if you have a specific search that you don't see in those groups, there's a search window that you can use. So in this example, the snapshot is showing what happens when you search for pregnancy. And when you find the resources that you're looking for, you can read a brief description. You can click on the link to the website. If there's a phone number, we try to provide that right up front so it's easy to see, easy to use. Each resource can easily be shared in several different formats by clicking on the share button at the bottom left corner of each box. And this gives you the option to share that resource via email or text message, or you can even print a hard copy and hand it to the patient to take home. So I've just shared a lot of information and resources with you. I've described the CQIs, the Collaborative Quality Initiatives of Michigan, and they're really unique models for quality improvement that allow for broad coverage across the state and an invaluable opportunity to reach thousands of patients to improve care. Other states are watching what we're doing, and several are putting similar models in place. The Michigan CQIs have become the gold standard in quality improvement. BBRs are one of several mechanisms in place that Blue Cross uses to incentivize providers to participate in quality improvement efforts, like the ones I've talked about today for smoking cessation. There are many, many wonderful resources available to help people quit smoking, not the least of which is the Michigan Tobacco Quit Line. We're working hard to uplift and share these wonderful groups and tools. HBOM has support and funding from Blue Cross. We have coverage across the state through our partnerships with other CQIs. And our mission is to connect the providers, patients, and resources to make the healthy choice the easy choice. As you are all well aware, tobacco cessation work is an incredibly challenging puzzle with a lot of pieces. Healthcare is one of these important pieces. Here's where we find patients who are experiencing a life-changing teachable moment. Gold standard, effective resources, such as the Michigan Tobacco Quit Line, are another incredibly important piece of this complex puzzle. Here, we find the clinically validated services that are so needed by the patients who want to quit. I like to think of HBOM as the hand that can help connect these two major puzzle pieces. Tobacco cessation work is challenging. We have a model to leverage broad statewide coverage, teachable moments, and gold standard quality improvements. Together, we can collaborate to provide support to all patients in Michigan who want to quit smoking. Thank you for your time. Thank you for inviting me here today. I have Laria, who is on our design team and has helped make these beautiful slides, and we're here to answer any questions you might have.
I just want to start, just thank you, Anne, for that. It seems like I hadn't seen some of those posters and stuff beforehand, and those are really great. I might have shared them out to some people during the presentation even. Laria has been answering most of the questions during the chat, but if anybody has any questions, please jump on now.
Yeah, thank you. I just wanted to highlight as well, because Karen put this in the chat, that you can request tobacco cessation materials directly from MDHHS, and we include these in every single request we get. We get like large quantities of materials from them, and people love them. We get wonderful feedback on the posters that have the ability to have the number tear off. Physicians love to have that in the office, so it can be patient initiated to take the information, as well as their referral cards. So I can't recommend those enough. They've been so popular that we just couldn't get enough of them. And so we ended up making our own version of them with the Quit Line material. So if anyone needs resources, that's a great thing to request.
I wondered if it's Lou Gamalski, and I work with a agency and that has harm reduction offices around Michigan. We have 8 locations, and currently we aren't tracking. So we have clients who come in, walk in, who just want syringe services, but we have contact with every person. We also offer medication-assisted treatment. So this is giving me ideas for our medical providing staff to be asking these questions, and then maybe we can begin to offer. Do you guys work only with medical professionals, or like social workers who, I provide counseling services within these practice environment. So when I worked in addiction treatment directly in a rehab, I offered every person the chance to quit tobacco. It's like, how free do you want to be? Because addiction is addiction is addiction. And you'll never have more support than you have here right now. So anyway, it was, I wondered if there was a chance that any of the therapists, they would be licensed master's level therapists, could be a provider that in this environment, that this type of thing you're working on.
That's a great question. And this is our first year, our first initiative, and the model that we have to work with because of the funding situation is through Blue Cross Blue Shield, through the hospitals and the providers. So we don't have that set up yet. However, we are exploring other initiatives, and so, you know, we love this feedback because for instance, one of the next initiatives we have planned to tackle is healthy eating. It's a pilot to work with people who have been diagnosed with type 2 diabetes, who are low income or food insecure, and to provide a jump start, 3 months worth of groceries that meet the criteria of low carbohydrates to help them, and we give them educational materials to kind of assist with what does healthy eating look like, what kind of food should I be ordering, you know, example recipes and meal plans and things like that. And so that is not using the same mechanism. That's actually a separate pilot that we received funding for from Blue Cross. And it's also a partnership that we have with Shipt Delivery, grocery delivery company. So as we continue to grow and grow and do these initiatives, we're establishing these partnerships, and we are happy to be creative with ways to think of how do we fund them. It all has to go through Blue Cross, but you know, they're very supportive of this wonderful opportunity to improve the health of people, of the population, because obviously that's just a really important piece of the puzzle that we haven't been able to tackle successfully.
Karen, you raised your hand.
Yes, Lou, I sent you an email in the chat, but this is something MDHHS is working on. And while we certainly don't have the great backing and funding of Blue Cross Blue Shield to do as large a initiative as HBOM is doing, we are actively working on that right now, and we are looking for clinics who want to do this kind of thing. So we would be happy to work with you, provide you support, and we could certainly get you on our email list if you're not already doing our trainings. We would love to have you and the rest of your clinic take advantage of those. So yeah, if you want to get a hold of me in the back channels and have a chat, I'd be glad to talk to you.
Thank you so much. And we always, you know, counsel on food because so many of the people, you know, haven't had access and or haven't been really caring for themselves in every possible way, they're themselves and their children. So I love what you're doing, Ann, and thank you, Karen.
Not seeing any more questions. Just thank you so much, Ann, for the presentation. Thank you, Kim and Holly, for earlier. I think we can move over to our lunch break now. Again, thank you, everybody. The next presenter is Minu Jones, who I've had the pleasure of working with and is also a TFM board member, talking about the local efforts around menthol and flavors bans in Detroit. This is part of a number of projects across the Midwest and South to try to reduce the impact that tobacco is having on rural and minority populations. Minu is a native Detroiter and the founder and CEO of Making It Count Community Development Corporation. And she also serves as the chair of the Detroit, Wayne, Oakland Tobacco-Free Coalition. The coalition's media campaign to end menthol and flavored tobacco sales was highlighted couple weeks ago at the CDC's AdFest campaign. Campaign materials are available for use on the CDC Media Campaign Resource Center for public use. She has done excellent work, and I highly recommend everybody checking that out. But with that, Minu, I will switch it over to you.
Okay, can you give me screen share rights, please?
Oh, I suppose I can give the yes. I did it for the old one. Now I can't find you.
I'm here.
Okay. Okay, how about now?
Yes. I got it. Right. Let's see. Where would we be? Okay. 1 second. Okay, can everybody see my screen?
Yes.
All right, so thank you. I hope you guys had a good lunch. I won't take up too much of your time today. I know that I think am I last on the list for today, Paul?
No, Amanda Gallagher is following you.
Okay, okay. All right. So we're going to just jump right into this. This is a modified presentation of the presentation that I did with Patricia Blake Smith and Lisa Knight from the Grand Rapids Urban League last month at the National Conference on Tobacco and Other Health. And, you know, we really wanted to highlight community-driven work to end the manufacturing and sale of menthol and all flavored tobacco products to protect youth and the public in general. Okay, so these are just some learning objectives, and what I really want you to get out of my presentation today is, you know, just how the tobacco industry has specifically targeted certain communities, and the community action model that we've been using to really drive this work from a community standpoint. So this is just a little bit of background information. And, you know, what we want you to know is that there are significant disparities associated with tobacco use. Even though Black and Brown communities are not the largest users of tobacco products, in some cases, they are disproportionately affected with death and disease. And this is a result of decades of targeting by the tobacco industry to those communities. And, you know, also, it's a result of us not having access to systems that we need in order to prevent us from starting in the first place, but also to help us quit. So as I said before, we worked with the Urban League, and we have a number of partners. Making It Count Community Development Corporation, we received a 3-year grant from the Michigan Department of Health and Human Services Tobacco Section to address tobacco-related disparities, specifically in Wayne County, the city of Detroit, and Oakland. But the project has grown. So there's similar effort occurring over in Grand Rapids, as well as Washtenaw now. So these are some of my partners in this work. We actually have driven this work through the Detroit Wayne Oakland Tobacco Free Coalition. where we have grown from 40 membership base to over 100 members. We meet monthly, the third Friday of every month from 9:30 to 11 a.m. via Zoom. So that's a plug, of course, for you to get involved in our coalition. We have national partners as well as state, local, grassroots partners and individuals. This is just some information about the Urban Leagues and organization. Lisa is not presenting with me today, but you should know that they do, the Urban League does a lot of work around social determinants of health. So, everything from transportation to safety, education, health, they do it all. The biggest point that I alluded to earlier is that it is not haphazard or a mistake that African Americans and other minorities, LGBTQ plus community, Native Americans, it's not, and Hispanic, Arab Americans, it is not an accident that we have higher rates of death and disease. It is a result of the tobacco industry targeting us with a lower price for tobacco products in many cases. Also, the proliferation of signage in our community, and the availability and sale at the point of sale, so at the registers, plastered on the registers, in the windows, in our magazines, and back when I was growing up, there was a thing you may remember called the Cool Jazz Mix Festival. So that was a marketing tactic by the tobacco company, really to play and interweave their messages into our culture. And I've talked about personally experiencing that, and I will just share a small story with you that I've talked about. So some time ago, my mom worked for an advertising agency in the city of Detroit. And I would say this was a good 30 years ago, but at that time, the advertising agency that she worked for, which was located in Detroit, landed a contract with the tobacco industry to give out free cigarettes. And models, which were just women in the community, mothers, young girls, that were attractive, were hired as models and paid $10 an hour to hand out free cigarettes at the festivals in downtown Detroit. And they had on these gold plastic jumpsuits, and it was summertime, so it was extremely hot. And the models, of course, minimum wage at that time was around $3.85. So $10 was big money. They were burning up hot, and they were just trying to get rid of these bags of cigarettes. So as you can imagine, they were just handing them out to any and everybody. And, the tobacco industry continues to infiltrate our communities and target us. So, here are some other examples, because it's, not just the Black community that's being targeted. They're targeting Latino, Latinx, and the LGBTQ community with their products. So, in terms of marketing, the tobacco industry really has focused their cigarette advertising and promotion of menthol cigarettes towards African Americans through their messaging and images. I can remember growing up in Jet magazine, every other page, there was a Newport or Cool ad. And, you know, the thing that we need to understand and put into perspective is that, you know, back in the 50s and 60s and early 70s, African American magazines and African Americans were not getting a fair shake and a fair deal when it came to getting sponsorships or high paying jobs in corporate America or for magazines. And guess who was right there to give African Americans the first jobs, you know, higher executive jobs? It was the tobacco industry. And guess who was there to help fund Black magazines? It was the tobacco industry. And so, you know, the challenge, of course, has been to help communities understand that even though they have been behind funding, it has not been to our advantage, it's been to our demise. They have, you know, created messages that reflect Black culture, you know, and have used our Black influencers and leaders and the things that you know, are a part of our culture to lure us in and create a culture of menthol tobacco use that today is 85% of African American smokers exclusively smoke menthol products. In the 50s, it was 5%. So I just am going to leave this picture here for a minute for you to, you know, consider and really look at what they have done. On the left side of your screen, you see Jim Crow illustration. And on the right-hand side of your screen, if you look at the Black man, he has the exact same pose for Newport ad. And, you know, it's sad. It's sad to see that they have preyed upon Black and brown communities. They're preying upon all children with their flavored tobacco products. You know, and we as a coalition, as a people, we have to band together to educate the community and stop this. These are more pictures, evidence of, you know, athletes and actors, musicians. You know, again, I see Jet magazine there with Little Richard. So here is, oops, let me go back. Oh, sorry about that. Little technical difficulty. Let me see if I can get back to this. I want to go back. All right. I'm gonna, you know how technology is your friend until it isn't. I'm gonna see if I can, oh, nope, here we go. Thank you for being patient. I really want to play this for you, but it's not playing. What it is it is a video called How Long Will You Target Me? And you can check it out on YouTube. I'm sorry I'm not able to share it with you right now, but it's a very good video. You know, it really lays out in an artistic way the tobacco industry's targeting of Black and Brown communities, and I encourage you to use it when you are educating the community about this issue. So this is just information provided by TFK, and you know, this is it's crazy, right? Because most older adults are want to quit. Most older adults who smoke cigarettes want to quit, and the tobacco industry, you know, knows that, and they've created thousands of flavored products to lure in new customers. And you know, I kind of glanced at the audience today. For me, I worked in tobacco prevention now for or tobacco control for almost 20 years. And you know, I remember when the Food and Drug Administration was given authority to regulate tobacco products, and we were looking at, you know, at the state level and local level, we were looking for designated youth tobacco use representatives who go out and do the tobacco compliance checks to check retailers to make sure that they were in compliance with the Youth Tobacco Act law. But at that time, of course, we were not looking at surveying retailers for sales of other flavored tobacco products other than cigarettes. And I remember, you know, I'm just being transparent and honest. I remember, you know, being so frustrated because it wasn't the cigarettes the kids were buying. It was the Swisher Sweets. It was the cigarillos. It was the Black and Milds. And, you know, look at the problem that we have today. You know, just more startling information. We know that menthol, it masks the taste. It makes it easier to go down, but it also makes it harder for people to quit. I said this before, and you can see down in the lower right-hand corner, just the amount of signage there. And that's common. When I was with the state of Michigan and overseeing the Food and Drug Administration's tobacco compliance check project for the state of Michigan, along with Carolyn Foxhall at that time. You know, we did youth decoy training, and we would have kids from as far up as Charlevoix and Sheboygan, all the way down to, you know, Wayne County and in Muskegon. And when I would do the youth training, I would provide pictures of different retail outlets, actual pictures of tobacco retail outlets, and ask the kids, you know, would you feel safe going into this store? And as you can probably imagine, the youth who were in the UP, they looked at a picture like this one down in the lower right-hand screen and would say, yeah, no, I don't feel comfortable. I would not go into that store. And, you know, it's not about who you see standing out the store. It's the condition of the store. It's the signage, the bars on the windows and all of that other stuff. Well, you wouldn't hear that from youth down in Detroit. They look at it and say, or Southeast Michigan, they look at it and say, oh yeah, I don't see any problem. I go in that store. And, you know, it's just a stark difference in the amount of advertising signage that is in urban communities on storefronts and in the stores, point of sales, access to products that should be behind the counter. That's more prevalent in urban communities than it is in other parts of our state. And, you know, we know that that's the same thing around the country. So when we talk about the community action model, and Paul, you know, I can go forever. So you're gonna have to be my timekeeper and keep track of keep track of time for me. But basically, you know, through my background and what we know with the community action model is you want to use a data-driven approach to this work, whether it's tobacco or some other health issue. You know, the data gives you an opportunity to look at it and prioritize the concerns of the community, and then plan out the work. And it's also an opportunity, of course, to engage stakeholders and provide more education. So, you know, as we do this work, here are the, you know, some of the questions that we are asking in the coalition and in the community, because the numbers only tell one part of the story, right? The other part is the qualitative part, and really understanding the challenges within the community, you know, and what their concerns are, what they are experiencing. And so, you know, we gather local level data, county, statewide. We look at that data. You can do some comparisons, you know, between national data, state data, and your local data to really prioritize needs for the community. And, you know, one of the things that I always say is the more localized data you can get, the better. So your coalition, your organizations, you know, there is value in you conducting your own surveys when possible, or partnering and leaning in to other organizations to help collect data and create a comprehensive needs assessment. So, you know, this is more resources of where you can find reliable sources of data. You know, we are very internet savvy. Google and YouTube University are out there, but we need to be mindful that there is bad resources out there, or invalid resources for data and research, and those that are valid. So, you know, here is some data from the tobacco use amongst African Americans in Michigan. And you can see, regardless of age, sexual orientation, income, or other factors, menthol is where it's at. Ooh, that's difficult to see. But it's, you know, this is really sharing more of that same information across the board. I need to move my bar, excuse me. So this is the percent of African Americans who would like to quit tobacco use now by age group. So, you know, when we, and I said this earlier, like most people who are current users of tobacco products want to quit. So these are some healthcare costs that Lisa Knight presented on. at the conference, and it's just a more compelling argument for why we need to address menthol and all flavored tobacco. It's an issue of health, and it's an issue of costs associated with it. These graphs, these are from Grand Rapids and or Kent County, and what Lisa was showing really here was that when you look at death and disease and disparities, the darker marking here on all of these health related issues, they are right there in Grand Rapids. They're in the inner city. They're highest in the inner city. And on the SES scale, we know that the communities with lower income, they're more likely to report poor physical and mental health, stress, low access to care, and tobacco use, right? We, as a community, and just individually, you may have heard people say, oh, well, I'm stressed out, I need something to cope. Well, menthol and tobacco is not your friend, and it's not helping us. We have launched our End Menthol campaign. We actually launched it in September of last year. And as Paul said in the introductions, our campaign, the End Menthol campaign, was accepted into the Office of Smoking and Health's Media Campaign Resource Center, MCRC. And so all of the collateral is available for public use and download. But you can also just go directly to endmenthol.org and get the information, videos, fact sheets, social media banners there, as well as resources for quitting, talking points, and facts on this topic, and a resolution of support. So this is the community action model, guys. And it's a five-step process. And we have been working with the Detroit Wayne Oakland Tobacco Coalition to really take them through this, or I should say us, take us through this process. And it is working. And, the other part of this is this process is transferable to other issues. It's really about building the capacity of the community to address disparities or health related issues. So for us, you see step one, it says train participants, name the issue, choose area of focus. So we've been very fortunate to have the Center for Black Health and Equity lead us in the effort to train the coalition. We completed a 5-part training series. And through that process, we were able to go through, identify what the priority issue was. It started off as menthol, but it grew to not just be mentholated tobacco products, but all flavored tobacco products, including menthol. We have targeted areas for this effort. It's Detroit, Wayne County, and it's expanded, of course, as I said before, to Oakland, Washtenaw, and Grand Rapids is also doing a similar effort in Kent County. And then, from there, after the participants are trained or your coalition members are trained, they work together to develop a community mobilization plan, break out into committees, and really make sure that you are leveraging the expertise and resources from each of your coalition members to participate in in a specific committee that is going to help you push forward your efforts. For us, we have 5 committees. But before I say that, let me get back to this. So one of the things that we did early on with our training from the Center for Black Health and Equity, you heard me say earlier that our membership has grown exponentially. Well, that was because when we first started our training with the Center for Black Health and Equity to do the community action model, we did a coalition readiness assessment and a community readiness assessment. And in the coalition readiness assessment, what we found with that was that our coalition was heavily based in individuals and organizations from the public health sector. But there were other sectors that should be at the table that were not represented. And so, what we did was we identified those sectors that weren't at the table, and we looked at within our membership who had relationships with those other sectors, like the faith-based sector or the school sector, the LGBTQ plus community, which was, not represented at our coalition at that present time, Arab American, Chaldean, Native American, media, who in the media sector could we lean on? And then once we looked at that and those personal relationships or professional relationships, we asked our coalition members to reach out to those organizations and individuals and invite them to our coalition. And it's been working. It's been working. So, here is and I'll share this presentation with Paul, but, from the Office of Drug Control Policy, when you are building a community coalition specifically to address substance abuse prevention, the Drug-Free Community Support Program recommends that you have representation from all 12 sectors. And so here are the sectors up here, but the other organizations, there are other organizations that are still not really represented here, and I would say those are associations. And I think most coalitions, in my experience, have, gone through or included the Chamber of Commerce in their work. But, I challenge you to, even within that, dig a little bit deeper, look at, what is the labor force? What does the labor force look like in your community? And if they have an association, include them, right? For Detroit and really Southeast Michigan, we are the automotive industry. That's what Michigan, is known for. That's what Detroit is known for. And so we have Coalition for Black Trade Unions who are a part of our coalition, and skills trade as well. I see some chats. Let me see. Okay, that's just Paul. And so, here are just a few of our supporting partners. Definitely not all of them, but there is room at the table for everyone. Oops. So I talked about the committees that we have. And these are the 5 committees that we currently have. There's a policy committee. They have really been working on the model policy language and drafting language. So that's their data and evaluation has been very helpful, in pulling state, local, and county dates, specific data, as well as surveys and developing polling questions specifically towards this effort to end menthol and all flavored tobacco products. And that information, has not only been used for us to plan out our activities, but also to educate the community, create infographics, and really raise community awareness and support the efforts of our education and community mobilization committees. Cessation, we know, of course, that we can't say we want to reduce tobacco related disparities without providing people with support to quit and kick the habit for good. So our cessation committee has developed a resource guide, and we continue to work in all areas. This past weekend, we were at the African World Festival. We did a funeral activation there to educate the community in an interesting and fun way that was also informative. And this is just a few of the people who are involved in the coalition. They attended the activation in September, but in this picture, just to kind of get an idea of the range of partners that we have. There's Latanya Allen Brown from Henry Ford Health Systems, Tracy King, she's from the Detroit Department of Health. In the middle, that is actually Commissioner Monique Baker McCormick, who's a Wayne County Commissioner. Next to her is Chanika Hodges, who chaired our Community Mobilization Committee and works with a local prevention, treatment, and recovery program called Changing Lives and Staying Sober. Cara Thomas with Detroit Wayne Integrated Health, and her choir that she participates in, Derek Mylan and the crew, was the choir who actually sang at this last activation. And then on the far right end of the screen, that is Angela Wilson, and she's with Adults Agency on Aging. I think I said that right. But the bottom line, especially to this slide, is you want to leverage your personal and professional relationships. And I've even gone as far, and some people may think it's rude, but for me, I've even gone as far as, if I am in a meeting or a Zoom or a presentation and a presenter or during introduction, someone says something that I think might be of support to the coalition, or that we may be able to support them, I will inbox them or chat message them to invite them. So for our End Menthol campaign, we had Compass Strategies, which is a small business public relations and media firm that is in Detroit, and they worked with the coalition and our partners to develop the creative and messaging. And so we did billboards, radio spot, the live activation funeral. We have the End Menthol campaign website. We did streaming and social media ads, and the creative was to take old cigarette ads from like the 70s and recreate them to show what the truth was. And so, one of the other things I would say when you are executing and planning out this work is that you are making sure that the information that you are sharing, the way that you share it, not just the mediums that you use, or the the diversity of people that you use in the ads, but that the messaging is messaging that will resonate with your target audience. And I'm sure that, I'm not going to be able to show the video, which is a complete bummer. But these are pictures from it. So as you can see, like, these were just people who were in the area. This wasn't an invitation, right? These were people that were just walking around Detroit in this specific area. It's called the Skip, which is downtown Detroit. They heard the band, they heard the choir, they saw the hearse, they saw a second line band, and they were really drawn towards our activation event, just, based out of curiosity for what was going on. And the result of that was that people took out their cell phones, started going on social media, and really engaging and hearing what the actor, which was a pastor, a fake pastor, was saying about menthol and our fictitious character, Mike Menthol Williams. Which was, of course, all of the information that we wanted the audience to hear about the tobacco industry targeting people with their blacks with their menthol products and and all flavored tobacco products, as well as the harmful effects associated with it. So here is just more collateral. We actually had a hearse that was wrapped in the End Menthol campaign information. We passed out church fans. The information and QR code was on the back. And I don't know why none of this wants to play today. I'm very, very sorry. But I will make sure that we share the funeral, the radio spot, and the how long will you target me videos with you. Here are more ads from the End Menthol campaign. And none of my videos are playing, so that's just great. So, but you can see, like, the amount of media impressions that we had exceeded 1 million impressions. Just emphasizing once again that you need to have culturally relevant messages. The message, they're killing you on purpose. That is the unsugar-coated truth that resonates in the community. Again, here's the End Menthol website. And let me see, I can just, so it's right here. And you see, here is our fact page. Please, please, please go here and sign the pledge. I know Paul, if you haven't, he's been very helpful as the chair of the policy committee to be the keeper of our resolution. So please, please sign the pledge. Here are the campaign videos and assets. Additional resources. So our videos are here, and we are in the process of working to get the website updated because we've had more stuff come in, including media spots. As you see here, you can download it for Instagram, Facebook, different sizes. And of course, there's a contact piece here. So that is my time. And, you know, I like to leave it open for a few questions.
So thank you. And before other people jump in, when I send out the video links and all the follow-ups, I will make sure that the videos that you weren't able to play are in there. If you can just send me those links, I'll get them out.
Thank you.
Also, on the topic of following up, due to the personal information showing up during the lunch hour, it might be a couple extra days before I get them out because I'll need to download it, edit out that information, and then get it re-uploaded. But I will get the videos out without personal information. So, but yeah. So, anyways, back to Minu. What sort of questions do you guys have for her?
I have a question. I'm Lou Gamalski. I work for an agency in Northern Michigan, but we have like 8 locations. It's a harm reduction. So we work with those with substance use disorders, but actually my question is around general things. I've heard a lot of people talking in our circle of friends, and if the legislation about menthol comes up, there's a lot of pushback. What the heck? Why are they going after menthol? Menthol's been here forever. And I don't know what to say. So if you could give me a reasonable thing to say in reply, I would be grateful.
Thank you. I'm so happy you brought that. I'm so happy you brought that up. So, and you know, we have been getting, or you know, I've been getting pictures from cash register, you know, of cash registers actually in the UP that has, you know, tobacco endorsed messaging on there saying, stop, don't let the FDA take your tobacco. So this is what you should know and what you should say. The FDA was given authority to regulate the sale and manufacturing of tobacco products back in 2009. Shortly thereafter, in 2010, the Food and Drug Administration banned all flavored cigarettes, but they excluded menthol. It's a social justice issue. If African Americans are the largest users of menthol cigarettes and 45,000 Black lives are lost each year to tobacco, our lives matter just as much as everybody else's. It should have been banned along with all of the other flavors back in 2010. We need to ban it now.
Thank you so much. because my husband is one of them, and he doesn't even smoke, and he never did. So I'm sort of like, dude, this is about health and health
Yes.
of the community. And so anyway, thank you for
Yes.
that.
Yes, it
If you-
is a
if you
social
have a-
justice
a
issue.
way, it's a teachable moment. So I always try to be patient with that. It doesn't matter what color you are. If it's easier to start smoking because you use menthol,
Yep.
and then we want to kind of remove that. So the real harsh cigarette taste. Now,
Yep.
you have anything like young people around here, and I live up north, they don't even call it smoking. They call it vaping. So what are your thoughts on that? Just,
Well,
in general.
yeah, so, vaping, people have the argument that vaping is harm reduction. While it may be considered harm reduction, it's not harmless. There are still harms associated with it. And the tobacco industry is looking to hook a new generation of users. So vaping is not safe. And I know I have, I saw I have Pave on the call today, Pave, Parents Against Vaping E-Cigarettes. They are a great resource when it comes to education, specifically around e-cigarettes and youth.
And Lou, in the chat, I also put together a little toolkit around the FDA menthol, but there's some talking points from the Public Health Law Center that I think you will help answer your questions in a little more depth.
Thank you, guys. I really, really appreciate that.
Thank you, Libby.
Any other questions? Nope, just more keep up the good work. Thanks, Gara. From Gara. Okay, well, thank you, Minu. I really appreciate you being able to squeeze the time in with all those other meetings popping up today.
Thank you. I'm so sorry. But I am encouraged by our participation here today. I believe that together we can really change some things in Michigan to protect our youth and vulnerable populations.
Yeah, and really just similar to working with the Health and Equity Action Team earlier, working with the Detroit, Wayne, Oakland Tobacco Coalition has been a really great experience. If any of you guys are in Wayne County or in Grand Rapids, obviously the different coalition, I very strongly recommend you guys joining into those coalitions. But in the interest of getting done and getting you guys out of here on time, I'm not going to ramble on, and I'm going to switch it over to Amanda and Michelle. Amanda Gallagher is the public health consultant and tobacco policy specialist for the Department of Health and Human Services Tobacco Control Program. She provides a lot of training and technical assistance to support tobacco control policies across Michigan. Before she joined Health and Human Services, she worked as a nonpartisan research analyst with the legislature and in community health in the nonprofit sector. She has a Master's of Public Health and Bachelor's of Science in Neuroscience from the University of Michigan. And she is being joined by Michelle Chalier, who is a certified prevention specialist and has worked with tobacco health in Delta and Menominee counties for the last 7 years. She loves working with youth in schools and enjoys living in the UP. So you're not alone up there, Lou. But with that, it's over to you two.
Thank you, Paul. And I will go ahead and share my screen. See that all right. And can you hear me?
We are,
Can
yeah, there you go.
Okay. Yep.
Perfect.
Okay. All right. So thank you for the introduction, Paul. I will be starting out the presentation and then I will pass it over to Michelle for a little bit to talk specifically about schools. But today we're going to be talking about moving towards the tobacco endgame with local policy change. And really the objectives of this presentation are to give everybody updates about what is happening in terms of local policy change to move us towards that tobacco end game, and to really highlight a lot of sources that have developed and give people the tools that they need to be able to enact some of these changes in their communities. So what is the commercial tobacco endgame? I typically say commercial to clarify that we're not a traditional religious use of tobacco by American Indians. So what is the commercial tobacco endgame? So some states and also countries are shifting their perspective from the perspective of tobacco control and just simply regulating tobacco to talking about the commercial tobacco endgame. And some examples of this include California, who has completely eliminate the commercial tobacco epidemic for all population groups by 2035. Another example type of policy was one that was passed in Brookline, Massachusetts, which prohibited the sale of tobacco products and e-cigarettes to anyone born on or after January 1st, 2000. So, you know, for most states, that date changes as people get older, but they set a hard date. So these types of endgame initiatives aim to permanently change or eliminate the structural and social dynamics that sustain the tobacco epidemic. So they don't necessarily result in complete bans, but basically create an environment where people are unlikely to smoke, are unlikely to start smoking.
Amanda, I'm gonna interrupt real quickly.
Okay.
You're getting a lot of echo, and I'm getting your bandwidth is low. I'm gonna take over sharing your slide so that that's coming from my bandwidth and not yours.
Okay.
Does that, if that works for you?
Sure, I can stop video too, if that's helpful.
That might help, yeah.
Is that any better?
It was cutting in and out, but yeah, let's go ahead and try it without video, and
Okay.
that way you can continue to control your own slides.
Yeah, sorry about that. I received a notification earlier that there's going to be gigantic storms in the eastern part of Michigan, so hopefully that's not impacting anything. So yeah, feel free to stop me if I get choppy again. Endgame policies, I'm going to go over some examples. So first, creating smoke-free and tobacco-free places. So this means things like tobacco-free parks and beaches, tobacco-free K through 12 schools, smoke-free multi-unit and tobacco-free college and university campuses. also retail policies, which can be really impactful on whether people have whether youth have access to tobacco, prevalent, these types of products. To be able to be purchased locations can be things like tobacco retail licensing, and I think as Michigan still does not have any tobacco licensing at the state level. Talked about is flavored tobacco restrictions. Some other types of policies can include things like raising the prices of tobacco products or the taxes on them. Retailer free zones, such as zones around schools or other areas tend also prohibiting sales of tobacco in pharmacies or limiting sales to adult-only locations. So today I'm primarily going to be focused on the ones at the top, the smoke-free and tobacco-free places. So for each of these, I'm going to talk a little bit about where we are in Michigan, where we're going, the types of resources that we have available, and what could be done to address some of these in your own community. And as is in the presentation title, these are really focused on local level policies as opposed to state level policies. So that might be an ordinance or it might be an organizational policy or item. So, and they have a lot of things in common across all of these different areas of policies. A huge social norms and really changing what is normal or tobacco use, including e-cigarettes in public places, by making it less normal, less acceptable. That changes the amount that people feel comfortable using these products in public. Also, really important part of these policies is their ability to reduce exposure to secondhand and third-hand smoke and also e-cigarette aerosol. So most people probably know about secondhand smoke, or the smoke that comes off of somebody else smoking. Another one that people might be a little less familiar with is third-hand smoke, which is really the particles that tend to land on different surfaces on your hair, things like that. Like if you walk into a room that where somebody previously smoked, you can tell. So these policies are important for me. What is good behavior for youth, because youth for sure, particularly when they're younger, become familiar with what adults are doing. A lot of time, communities and policies encourage or whenever possible, might be included in the actual policy. It might be, as Minu talked about, really pairing a policy with an effort to support cessation. Also, these policies can benefit the environment, including things like the protecting wildlife, protecting habitats, preventing fires, from reducing tobacco litter. Also, let's see. So another thing that I'm noticing a couple of comments about my quality. So I'm wondering if it would be good for me to switch over to phone audio or something. Are you hearing me okay, Paul?
You were sounding good until you just asked if I was hearing you okay, and then it came out very slow.
Okay.
But
should I try to switch or keep going?
Sorry,
everybody.
Yeah. I think you're okay to keep going.
Okay. Everybody will have access to the slides if you miss anything. So let's see. So the last thing on this slide is benefits to maintenance, particularly for parks, housing, universities, that these types of policies can reduce the costs associated with maintenance and staffing. And those are points that are really important to highlight with those types of entities beyond just the health benefits. So I wanted this to be interactive. So I wanted to start out with a question for people in the chat. And hopefully this presentation will help everyone answer this question. But what is one thing other, I'm gonna say other than funding, because wouldn't we all like more funding, but what is one thing that would make it easier for you to work on one of these, as I mentioned, more specifically focusing on tobacco-free and smoke-free places? So I'm just going to give everybody a moment to think about that. These are just a few ideas that I threw in to the chat or that I put on the slide, but yeah, so what is one thing that would make it easier for you to work on one of these policies? It could be a strategy meeting, technical assistance, information about whether there are existing policies in your area or not. More general training that's more policy specific, talking smoke-free housing, or it could be, additional technical assistance resources, other ideas. Feel free to drop something in the chat.
While people are thinking about that, Amanda, your audio is starting to break up again.
Okay, I'm gonna try to switch to phone
Okay.
while people are thinking about that. Sorry about that. It's probably a bandwidth issue.
Okay, can you hear me better? I'm on phones now.
Much, much better.
Okay. So let's see, a couple of people have started putting things in the chat. Erin said community support. Lou said it would be helpful if drug, alcohol treatment facilities were required to be completely tobacco-free. And that is something that Karen Brown, my colleague who spoke up earlier, will connect with you about, Lou. Other things that people have listed, incorporating smoking cessation as part of other CUD and AUD have been addressed. Okay, I'm gonna go ahead and keep moving forward. So first, I'm gonna start talking about tobacco-free parks. I will say that there has been a great deal of work on this, some of it specifically by our partners and some not so much. So this is something that we try to track, and I have documented that there are at least 156 tobacco-free or smoke-free parks policies in the state of Michigan. Those include ordinances, which are really the strongest type of policy. There are resolutions, which are considered much more temporary. There also are sometimes park rules or private policies for places that aren't public parks. Sometimes places only have posted signage. So there's really a range of how strong these different policies are. Some of them are 100% tobacco free. Some of them allow use of some tobacco products, but don't allow smoking. So definitely can be opportunities to strengthen these policies. So at least 47 cities and townships have passed ordinances. So whenever people have a copy of this presentation, I encourage you to take a closer look. Is there maybe a city, township, village that you're in or is near you that does or doesn't have a policy? This would be a great opportunity to do that comparison. I wanted to highlight some of the tobacco-free parks and beaches resources that we have. And I've included links in the presentation that can be clicked on later. And I believe Paul is also going to assist with placing some links in the chat. But just a few things that we have that we can utilize to support people in this work. There is a database of policies, like I referenced briefly. We try to keep track of how strong the policies are and keep copies of them, so we can help you check to see if you have one already or not. We have a stakeholder presentation that could be used to present to, say, a city council or something like that, a local board, to educate them about the importance of tobacco-free parks and beaches. We have fact sheets, talking points, model policies. The ordinance in particular was updated recently. There's also a tobacco product waste cleanup guide. So this can be a really impactful activity that is particularly good to do with youth, or it could be done with environmental groups that can show, you can collect cigarette butt waste and really show how much tobacco waste you're finding in your park. We also specifically created a handout on ceremonial tobacco use of traditional tobacco in parks and on beaches, and how to navigate that well. We can help provide technical assistance on that. And we also have examples of signage. So a few things that we're doing to try to support these efforts. We work with partners who are working on these as part of specific contracts, or it could be much less formally. For example, if you're part of a coalition that is funded through other sources that's interested in working on this, we can provide support to you as well. So we can help with basically all of the different steps of these types of policies, how to educate stakeholders about policies, how to adopt one, how to implement it. We can also provide specific feedback, plus with the help of other partners, such as the Smoke-Free Environments Law Project, take a look at an existing policy and be able to look at it and see if there could be opportunities that would make it stronger. So are the parks in your area tobacco-free? Encourage you to check the status of your local park. Maybe there's signage, maybe there's not, maybe you have an ordinance. You could contact us to check on what those lists look like. You could also contact your local parks department or city, township, village council to share information with them. And then particularly for larger, more resistant jurisdictions, really encourage the work of a coalition. Some of these projects, such as the one that was passed for Grand Rapids with really big cities, do require a much broader show of community support in order to pass these policies. I think particularly for smaller jurisdictions, sometimes you might be able to do as much as, you know, send them a letter or contact them to share information about the importance of tobacco-free parks. So it might vary significantly based on how big your jurisdiction is, or potentially how resistant a board or other decision makers might be in adopting a policy like this. So I'm going to really be going through quite a few different topics and resources. Now I will be talking about some of the work that has been done on tobacco-free schools. So where are we now? So back in 2019, we did a really comprehensive look at all of the different K through 12, all of the different K through 12 tobacco-free school policies. So this is what we found at that time. There has been a little bit of improvement that I have added in here. Thanks to the partner who is about to co-present with me. So 510 schools had really comprehensive 24/7, 365 tobacco-free policies, whereas 306 at last check still had fairly weak policies. So this is really something, I think a lot of people assume that schools are on top of it, but there are still quite a few that could use your help with strengthening their policies. So this is definitely some progress that we've seen over these years, but also a long way to go. So similar to with parks, we offer a lot of different types of training and technical assistance with adopting model policies and implementing them. We have a policy that we recommend, also can have recommendations. You know, maybe you're with the health department or another group that does education in schools, can help provide recommendations for example, tobacco prevention curricula, or how to navigate alternatives to suspension. So again, a great question to ask is, are the schools in your area tobacco free? And that's something that we can help you figure out. But I wanted to really highlight the work of one of our contractors that we work with. They have done really fantastic work related to tobacco-free schools in the last few years. So Michelle Shaler from Public Health Delta and Menominee counties will be talking a little bit about what they have done on their tobacco-free schools work.
Hello, and thank you, Amanda. So yes, my name's Michelle Shaler. Can everybody hear me okay?
Yep, we can hear you, Michelle.
Perfect. So we cover 14 of the 15 counties in the UP, and this has been one of our initiatives on the last few years. So if we go to the next slide here, looking at the emergence of vaping and when that first started, it really changed the language for schools. It threw them for a loop. A lot of our schools had really good policies in place, but they were smoke-free policies. They weren't tobacco-free policies or nicotine-free policies. So this big change happened, and then we had targeting towards youth. We have sweatshirts with like you can hide the vaping in the strings in your sweatshirt. We had kind of like Minu talked about earlier, how people think vaping is safer. Kids hear safer, they think safe. So we ended up having massive issues in the schools. And I've spent my last 7 years in the schools. And when I started up in the UP, vaping was not a thing. Didn't get talked about. It wasn't, I'm sure it was around, but not in our rural area. And then over the course of my time, it started trickling in at the high school level, then the middle school level, and sadly, even at the elementary school level. And the schools didn't know what to do. They didn't have those policies in place. They didn't know if, should we suspend, should we teach? They were really ill prepared to deal with it. And so we, my colleague and I started this by really just researching, what do our county's school policies look like? And I just highlighted a couple on the next slide here. The first one was a really good policy before vaping was a thing. I won't read you the entire thing, but if you get towards the end of it, it talks about we are trying to set a good example for our students by modeling correct behavior. Volunteers, chaperones are not allowed to smoke on school-sponsored events. all visitors and adults abide by this rule. So very student health thinking, but didn't even manage to get to it when vaping became a problem. So we had a lot of policies that were like that. And then the second one was a little bit different. If you also, again, I'll skip the beginning and I just bolded the part at the bottom. Tobacco may be used in designated outdoor areas on school property on Saturday, Sunday, and after 6 p.m. on days which there are regularly scheduled school hours. And that's very extremely outdated. But again, we are very rural. And if we look at certain schools, certain school boards, and certain influential parents, we see that some of these policies tend to favor those outdated practices. This particular school allowed for parents to smoke, frankly, in the building while watching student sporting events and just leave their cigarettes out the door or out the window, not out the window, out the door. So we saw kind of a really vast array of school policies. And then there were some that were on top of it. They had 24/7 comprehensive policies already in place as we were researching this. So if you want to see on the next slide, we have what the Michigan State Board of Education recommends. They are very specific. Schools should prohibit the use of any tobacco product in all school-related situations by any person at any time, in any location, at any event. So no matter what, if you're on a school property, if you are on a school event, anything, they don't want any kind of tobacco, any kind of nicotine, no vaping, no nothing. And we all, we in our line of work know the health reasons for that. So it's just really looking at how can we best address that with our schools. And so what we did up here is, I'll talk about some of the things we did, and I have a few pictures too on the next slide. We started out by reaching out first to the schools that had already built in those excellent policies. We thanked them for what they were doing. And then we offered with grant dollars to purchase these signs, tobacco-free, vape-free, drug-free schools. And again, if they had those policies in place, we asked, what are your school colors? What is your school logo? And we individualized them for those schools. They all got, I think it was about 12 signs per school. The idea being they could be posted at entrances, gyms, bathrooms, kind of wherever the school felt would best fit. And we also were able to purchase a lot of extra generic ones so that in future years, we were able to, as we worked with other schools, we could still give them signage, even though it wouldn't be personalized. A lot of the schools were really excited to hear from us. The ones that had already made the change were grateful that they were acknowledged. They were happy to get free signage. The ones that hadn't, many of them really, they hadn't thought of it. We started this during COVID, so they had a lot of other priorities, but many of them, when we talked to them, were like, yep, that fits, we need this. And even, especially with COVID being, kind of lung related and vaping, so they felt it was a good fit. So many jumped on board and worked with us and worked with Amanda working with Amanda to create that 24/7 comprehensive language to get them where we'd like to see it. Just this last spring, we were able to start doing evidence-based programming in the schools for alternative to suspension. So students caught vaping could take this educational class. We actually, this first year, we just had the entire, I think it was the 9th grade. It was so well received, not just by the school and the staff and the administration, but by the students as well, which was really encouraging. So we're definitely seeing a change in attitudes towards vaping now that we're seeing more of the dangers come to light. And then I already talked about the signage. That's the second half of that. But our next slide will show a lot of the other schools that we were able to work with. So you'll see all of those were our personalized signs. And then going forward, as we work through our 14 other counties and other school districts within those counties, we should be able to provide signs for any of our schools that do decide to make this change. Last slide, just a couple things that we learned throughout the process. Some schools were very focused on COVID and did not have time to work with us. And we were persistent. That tends to work. We've also worked with other agencies in the community. We've had coalition members speak up, reach out to the schools. That one policy that I mentioned earlier, where they were really resistant to change. We worked with the principal. He didn't want to make any adjustments. We worked with local coalitions. They reached out to the superintendent. Some of them had a personal relationship where we didn't necessarily. And the superintendent was frankly shocked. And now that change is happening. So sometimes it's just finding somebody that can get in and make it known and make people aware. But we've had really good success. And I think it's really encouraging to see the progress, and the frankly, most of the schools have been excited about it. And those that aren't are still willing to make those changes, because it is important for our youth. I saw one question for evidence. Was that evidence-based? We started with In-Depth, which I believe is American Lung Association program. And we also have the ability to offer Catch My Breath, though we haven't tried that one yet. I think we'll start that this next school year and kind of give the schools the option of what they feel is the best program for their school.
Thank you so much, Michelle. And we'll also have more opportunities for questions towards the end if people are going through and think of any. Let's just go ahead and answer the question that we're.
These ones. So the question was, our alternative to suspension after school. In this case, this pilot program that we just did, I believe it was right during their gym class. So every student in 9th grade, instead of gym for a couple of weeks in a row, they took In-Depth. Some schools will probably opt for after school. I'm not really sure. That'll be a case-by-case basis, whatever the school feels fits best for them. One of our programs, my colleague pre-recorded a program, so they can actually send it to the school and they can play it as needed. And we won't even have to take up staff time to do it. So that's an option as well.
We're going to go ahead and move on to a couple more topics. But yeah, again, thank you, Michelle, for your hard work. And also I saw Erin Corrali, your colleague. You both have done really fantastic work in the UP on schools. So really happy to be able to highlight that. So briefly talk about some of the work that we've been doing on smoke-free multi-unit housing. I think for a long time, Michigan was really a leader in this space. There's been a little bit of a pause for a while, and we're hoping to get back into it. So just an update about where we are now with smoke-free housing. At the national level, only about 1 in 3 multi-unit housing residents are covered by smoke-free housing policies. One piece of great news that happened a few years ago was that 100% of public housing commissions have gone smoke-free. But sort of like what Michelle was mentioning with school policies is that a lot of them have not been updated to include e-cigarettes or maybe other newer products that have emerged in the last 5 years. So that's something to be aware of. There's also a lot of variation in what these policies look like with market rate housing and also with housing that's part of the Section 8 Housing Choice Voucher Program. One thing that is good news, Michigan's smoke-free indoor air law, which was passed quite a while ago now, all indoor common areas of apartment and condominium buildings must be smoke-free no matter what. But again, this policy, since it's a little bit older, does not address e-cigarettes, and so it does not prohibit them. So individual housing managers, property owners would need to adopt their own policy in order to fill this gap. So again, lots of different resources that we have related to this. A couple that specifically are newer, we recently updated our model lease addendum and house rules. We also have a new handout specifically related to e-cigarettes in order to try to fill that gap that I just mentioned in a few different areas with other policies where smoking is prohibited, but e-cigarettes and other tobacco products are still allowed. So lots of great resources to help locals who are interested in working on this. And I also specifically wanted to highlight a learning opportunity in case anybody's interested in going much deeper on this topic. So we are working with partners who work with asthma and health. They're having an asthma partnership forum that's coming up pretty soon on July 28th. So there will actually be presentations from a lot of our staff on several different topics. So I will be presenting on smoke-free housing. My colleague Elaine Lyon will be presenting on restricting menthol and flavored tobacco products. And then Karen Brown will also be talking about tobacco cessation. So if you sort of want a conference part 2, this is another great opportunity to learn about all of these different topics related to tobacco. And Paul dropped the link to the registration in the chat. So thank you, Paul. So I am kind of speeding through these, but I want to make sure that we have an opportunity to get to all of the different components and to highlight all of the great resources that we have to offer. So we've also recently started doing quite a bit of work on tobacco-free colleges and universities. So a big part of this, of getting back into this, we hadn't looked at where the policies for colleges and universities were in quite a while. And so I took a deep dive into all of the different policies and created this tobacco-free report card. And I'm really excited to be able to present this, I think, for the first time to everybody. This is the first time it's been mentioned, but it includes basically a rating of all of the different colleges and universities to show how strong their tobacco-free or smoke-free policies are. So the goal of creating this resource is to really create an education tool to be able for advocates to use to encourage them to make change, to encourage college and university leaders to make change related to their policies. It also is to determine the status of what these policies are at this point in time, so we can track progress over time. It also shows how schools compare to each other. I think school spirit, school competition can be something that's really important to highlight in this, just to leverage that sense of competition. And, you know, all of the fact that colleges are graded on so many different things related to quality, why not tobacco? So we found some things that were pretty striking to me. So I found that only 1 in 3 Michigan colleges and universities has a 100% tobacco-free or smoke-free policy. And that most of them have some sort of policy, but the reason they're not 100% tobacco-free or smoke-free is because a lot of them have different exemptions in them. So I'll go over what some of the examples of exemptions are on this slide. So the one piece of good news is the most common type of policy was policies that are 100% smoke-free and tobacco-free. And also a handful of those specifically talk about synthetic nicotine, not nicotine for cessation, but nicotine, but synthetic nicotine, such as in e-cigarettes. And a much smaller number of policies were smoke-free, but then not tobacco-free. So they allowed like the use of oral products like chewing tobacco or the pouches. A lot of schools had, 29% of schools had exemptions that allowed smoking in parking lots and private vehicles. Some people think that this is a good idea. So somebody just asked in the chat, where would we get a copy of the report? I believe Paul will be dropping that into the chat for me. So a lot of people think that having these parking lots and private vehicles allowed and designated smoking areas allowed are good ideas. But for example, secondhand smoke can be a serious issue in designated smoking areas. Smoking in a private vehicle can be really challenging, or can cause a lot of issues with health. These also affect, having these exemptions affect what we talked about earlier with social norms. They normalize the use of tobacco products in public. So we generally try to discourage having those exemptions. And there are also some policies that allow smoking around, or allow smoking in most places outside except for around the perimeter or entryways of buildings. And then the weakest type of policy is policies that only prohibit smoking or e-cigarette use in buildings, but don't have any policy for outdoor campus areas. So I was curious about e-cigarettes. One thing that I was pleased to see was that a majority of existing policies, even though the strength of them varied in other ways, most of them did include e-cigarettes. So, and you'll see in the report, I try to break this information down by type of college, public community colleges, public four-year colleges, and other public colleges and universities, and then I separate out private as well. So what are some things that we are working on related to this? Right now, primarily it's promoting this new tobacco-free college and university report card, sharing it directly with college and university administrators, at least considering the idea, depending on staff capacity, and creating a group that could support policy adoption and enforcement with this type of work. So if you're interested in that, please feel free to let me know, and I'll include my contact information later in the presentation, or you can message me. So highly encourage partners to look up colleges and universities in your area, or if you have a Michigan alma mater, reach out to them, maybe the office of the president, encourage them to strengthen their policies, share the report card with them, and that could be a relatively easy action item in letter form if you would like to do that. So again, include lots of different resources on our website. And Paul will help to drop the link in the chat. So we are prepared for, following the promotion of this. Really hope to get the ball rolling with these efforts. And one really important thing to mention, if anybody, does have relationships with colleges and universities, there are funding opportunities for this. So there are grants from the Truth Initiative where you can apply, where a college or university can apply to get up to $20,000 to support the adoption and implementation of a 100% tobacco and vape-free policy. So that includes a lot of different ways of supporting these efforts, and you can apply by October 12th. or not you, but a college or university can apply by October 12th. So there is a little bit of time to encourage them to do that. So it's always great when you want to work on a policy initiative and there is funding for it. And then one last resource that I wanted to highlight before we close out is that we have these tobacco policy workshop toolkits. And these toolkits are really trying to help all of you make it easier to be able to educate groups of youth or adults about policy in order to educate stakeholders about them. So I think a lot of people are intimidated by policy. Maybe you haven't done much policy work in the past. So these toolkits really make it much easier, try to break things down for people and give you ideas for how to talk about a specific topic. And also just a note for funding for people who can't lobby. These are non-lobbying policy education toolkits, and they don't address specific legislation. They're very general. So these resources include things like a sample agenda, a presentation on a timely policy topic, also a presentation on how to give a presentation to decision makers. They also include things like key policy messages on specific topics and leave behind materials that you could give to decision makers. So there are a few different ways that these could be used. It could be used for a presentation, such as at a city council meeting. It could be used to write a letter or email to decision makers, or it could be used to help prepare for a meeting. So one I really wanted to highlight, and a lot of support from this happened with the help of our partner, with the Smoke-Free Environments Law Project. We have the topic, a toolkit on including e-cigarettes in indoor clean air policies, because as I said, there are a lot of, the state policy does not address e-cigarettes indoors, and a lot of older policies do not either at the local level. And then Paul briefly talked about tobacco retail licensing. We have a toolkit for that. It also has a toolkit for tobacco-free parks and beaches, as well as one on flavored and menthol tobacco product sales ban. So we're really talking about a lot of the different topics that are really important right now, and that you all could have these resources to be able to educate your stakeholders about them. So again, if you're not sure what topic you would want to choose or where to start, people are welcome to reach out to me. I have included my email here, and we can also drop it in the chat at the end. I think since we're short on time, I'm gonna jump towards the end, but almost all of these resources can be found on our website, michigan.gov/tobacco. So all of these different pages can be found there with information about the topics that we talked about today: parks and beaches, housing, colleges and universities, plus including that report card, K through 12 school resources, and we also have some more general policy resources in our resource library. So I will stop there. I want to thank everybody for your time. I also want to thank Michelle for joining me for this presentation. I'm happy to answer any questions, or if time doesn't allow, then Paul dropped my email in the chat, and I am more than happy to help people with any of the different things that I talked about today.
Well, thank you, Amanda. Any questions for Amanda? Okay, so hearing none, just want to thank everybody for, well, that was not right. Sorry about that. So I want to get everybody out of here on time, and I will just post up this final thing. There is going to be, I will post a link in a moment to what is going on here. Sorry about this. There is a poll that I am trying to pull up, but Zoom has decided that I don't want to, even though we tested it out earlier. Give me one moment. This is very annoying.
Paul, if you're talking, you're on mute.
Okay, can people hear me now?
Yes, we can hear you.
Okay. Sorry about that. Don't know what entirely is happening. So just want to thank everybody for coming. I hope you guys all learned as much as I did about the whole variety of tobacco issues. I want to thank all of the presenters. I am throwing a link into the chat as well. This is the evaluation form. If you wanted continuing education credits, please fill it out. Especially there's a section 2 that has your contact information in it. That is where I will be sending the continuing education credits to. So, and even if you don't want the credits, please do fill it out so that we can try to make this better in the future. But with that, we've got 2 minutes left. I just really want to thank everybody for coming. If you have any comments or questions, please feel free to pop up. Likewise, if you just have any great stories about the work that you've been doing that you think others can learn from, feel free to unmute yourself and pop in. We only have a couple minutes because I do have a board meeting in 2 minutes, but yeah. So please fill out the questionnaire and the poll would be greatly appreciated. Thank you for the thumbs up, Merch. Cool. So with that, I will declare this meeting to be done. Thank you everybody for coming, and I look forward to hopefully seeing you at the quarterly meeting. I am still trying to work on trying to make that be an in-person meeting, if I can find a appropriate space. Okay. Sam, yes, the same link shared this morning to get the credits. That one of the questions is, were you here for the morning or the afternoon? So.
So 4 is the full webinar. Clicking on 4.
I'm sorry.
The last question, Paul.
Yeah.
Yeah. So if we attended all the sessions, we would click on 4.
It's 4. Yes.
Very good. Thank you so much.
2 if you were only here for the morning or the afternoon, and 4 if you were here for both morning and afternoon. No, Sharita, the one link will cover both of you. Just make sure that you select the 4 credits option. So, okay. So with that, thank you, everybody. We do have a TFM board meeting immediately following right now, so I am going to have to boot those of you that are hanging on, but I look forward to reading the evaluations in a moment, or tomorrow probably. And I will send out the video as soon as I can.
I'm going to stop recording.